Good morning, everyone. Welcome to our World TB Day webcast here at Heartland National TB Center. We hope everyone's having a fabulous day so far. And thank you so much for joining us just a skosh early, because we do know that World TB Day actually takes place on the 24th, but we're pretty sure that we would rather give it to you a little bit early than a little bit late, as is correct. So with that being said, let's go ahead and go over just a couple of things that have been rolling on the screen so far, because I just want to make sure that we are following our instructions as well, so everyone can get those sweet CE credits. So give me 1 second. First off, here at Heartland, we have a mission to collaborate with state, local, and public health partners to reduce the impact of TB. We will achieve this goal by sharing our expertise through state-of-the-art trainings addressing all aspects of TB, presenting cutting-edge knowledge to public health and private providers to benefit patients and their communities, as well as designing innovative educational and consultative resources. Our vision is to be the most patient-conscious professional healthcare organization focused on TB elimination. We pledge to support our public health and private partners to encourage use of safer, shorter, better tolerated TB treatment regimens to eliminate stigma and to decrease transmission of TB in our communities. If you aren't already aware, those of you in Texas, these are your main points of contact depending on your public health region. So we have Debbie, we have Salma, and we have Catalina. They are my personal inspiration here at Heartland. The work that they do is so important, and they are real life superheroes in actions. They just hide their capes in their closets. So if you are not already familiar with who it is that you've been speaking to or who you may want to reach out to, here's a friendly little resource that we have that you can also find on our medical consultation page. Speaking of medical consultations, here is our warm line that you can reach out to us with. And we do try to respond as soon as possible. That 24 business hours one, we might be stretching a bit from time to time. Don't think less of us for it. We're just incredibly busy serving the state of Texas, and we will try to get to you as soon as possible. Always an email is also very helpful, and you can also find that information based off of your point of contact on our medical consultation page on our official website. Now, as far as training and education is concerned, not only are we all joined today for our World TB Day training, but we do have a couple of upcoming trainings. The first one that's going to be coming up after World TB Day is our Essentials of TB Nurse Case Management online course. It's a level 2 course, so those of you that might have joined us earlier for our level 1 Intro to TB Nurse Case Management online course might want to consider hopping in on this. It's also a friendly little refresher course for those of you who have been around for a little bit, so feel free to join us for level 2 if you think it might be beneficial. We also have another webcast coming up called Understanding the IGRA, What You Need to Know, that's occurring on May the 2nd. Level 3 of our nurse case management training series is happening in June. We also have a screening and treating TB infection training that went very well back in February, just before World TB Day. So if you haven't already taken the opportunity to join us for that training, please feel free to come by. And then while you're at it, maybe take a TEST practicum course since it's the following day, and might as well since you're already in the area. Then we also have our Heartland newsletter for TBeat. You can find this, I believe, on our medical consultation page as well. We try to issue it whenever there's exciting news, such as case presentation highlights, regional highlights, resources that are fun and helpful for you folks that are out there doing great work. If you have a suggestion, please send it to Chelsea Hargrave at the following email, so that way she can take that into consideration when we make our next issue. And then I've been mentioning it all along, but if you haven't already visited our website, please feel free to do so. We have lots of information. We have archived training presentations. So if you need a refresher on a presentation that you've joined with us before, and you're just like, oh, I wonder if I can get that presentation again, it's already there and available on our website. You can also access our products via this page as well. And so if you need to order anything, please feel free to fill out an order form and Alicia will get it to you. Just keep in mind that we are only offering free shipping within the state of Texas, since they are our contractor. So anyone outside the state of Texas, I'm so sorry that I can't give you free shipping right now. Wish I could, but I can't, unfortunately. And then we also have our contact information for each of our team members on our About Us page. Also, we have a Facebook page, so if you haven't already joined our Facebook page, please feel free to drop by and give us a like and follow us for all of our fancy news and updates. And then, of course, we have some disclosures to go through. Now, this one is very important. I do have to read it kind of word for word, so that way we can all get those sweet, sweet continuing education credits. So first off, for successful completion, for this continuing education event, we do require everyone who is a participant to complete the registration and sign in. So that's what you have already done through constant contact leading up to today. Then we are asked, or we have to require that everyone attends the entire event, that you participate in educational activities, which in our case is not going to be terribly difficult since they're already here and joining us, and then completing a participant evaluation. And that part I will go over later after all of our speakers have presented their talks. So don't go anywhere just yet. Now, as far as the actual credits that have been awarded, I have the following disclosures to state. So for continuing medical education, or CMEs, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Texas Medical Association through the joint providership of the Texas Department of State Health Services, Continuing Education Service, and Heartland National TB Center. The Texas Department of State Health Services Continuing Education Service is accredited by the Texas Medical Association to provide continuing medical education for physicians. The Texas Department of State Health Services Continuing Education Service designates this live activity for a maximum of 2.75 AMA PRA Category 1 credits. Physicians should claim only the credits commensurate with the extent of their participation in the activity. And as a bonus, this course has been designated by the Texas Department of State Health Services Continuing Education Service for 0.75 credits of education in medical ethics and or professional responsibility. So that's a big one right there. Make sure you get that. Now, for my lovely, lovely nurses who are joining us, the Texas Department of State Health Services Continuing Education Service is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. So the Texas Department of State Health Services Continuing Education Service has awarded 2.75 contact hours of nursing continuing professional development to you guys. Continuing on, as far as commercial support and conflicts of interest, this particular event, World TB Day Webcast, has received no commercial support. The speakers and the planning committee members for this event have disclosed no relative financial interests. And then, as far as any off-label use for any products is concerned, we do not have any of those going on in any of our presentations. And of course, being accredited or the accreditation status of this event does not imply endorsement of any commercial products or services by the Texas Department of State Health Services, the Texas Medical Association, or the American Nurse Credentialing Center. So also, our speakers for today do not disclose the use of products for any purpose other than what has been approved for by the Food and Drug Administration. So thank you so much for sitting through my very, very long-winded little info dump right there. I know it was a lot, but I promise you it's for the greater good so that we can get those continuing education credits that I know that we all want. So if I am Lauren Fields, I will be guiding you throughout the entirety of our World TB Day webcast by introducing some of our speakers, giving you all instructions, and if you have any questions about anything related to our World TB Day webcast, please feel free to give me a shout at my email that's right there on screen at lauren.warren-fields@uthct.edu, and I'll be happy to assist you in whatever way I can. So next we have our very first speaker that's coming up on deck, and I'm very excited to announce that we have excuse me, that our very first speaker is Annette Costa. Annette leads the epidemiology team at the DSHS TB and Hansen's disease program. She and her team provide support to the TB and Hansen's disease program and their contracted health departments on concerns related to contact investigations and public health follow-up, travel restrictions, data management, and data analysis. She is also intricately involved in surveillance and the detection of TB clusters and outbreaks by use of molecular epidemiology and field data. Annette has been working with public health and TB since 2017, and she joined the DSHS TB program in 2019 as an epidemiologist. She serves as epidemiology team lead since 2020. So she's been around a while, and she's got some great information that she's going to drop on you guys in just a moment. And if you haven't already done so, please feel free to go ahead and drop your name in the chat just to make sure that we record your attendance during World TB Day's webcast. It's very, very important as well. And then, of course, for those of you in a group setting, a file has been shared as a pinned comment for you to be able to fill out and complete by the end of the World TB Day webcast. So with that being said, Annette, I think I've got them all primed and ready to go for you, ma'am.
All right. Good morning, everyone. Thank you, Lauren. Let me know if you can hear me all right.
Yes, ma'am, we sure can.
Perfect. So good morning, everyone. My name is Annette Costa. I am the epidemiology team lead here at the Tuberculosis Enhances Disease Unit with the Texas Department of State Health Services. And today I will be talking to you about tuberculosis in Texas, current numbers and challenges. And before I begin my presentation, I just want to say that I have no conflict of interest or financial disclosures. So we'll start our presentation today looking at the incidence and distribution of tuberculosis in Texas. Tuberculosis, or TB, continues to be a concerning condition for public health in the United States. Texas continues to have the second highest number of TB cases in the nation, behind only the state of California. Our state also has one of the highest incident rates of tuberculosis in the country. You can see that in this graph that during the COVID-19 pandemic, especially in 2020, there was a sharp decrease in the number of TB cases reported in our state. This trend was seen in most of the country as well and can be attributed to many factors associated with the COVID-19 pandemic. In 2021 and 2022, our case count started to recover and started to inch closer to pre-pandemic levels. In 2023, that growing trend continued, and we registered a total of 1,235 TB cases in the state of Texas. I do want to highlight that, this growing trend actually surpassed our pre-pandemic expectations, and the case count in 2023 was the highest case count in Texas since the year of 2015. So we are seeing an increase in our tuberculosis cases. TB is found around the entire state. As you can see in this map, many of the 2,054 counties in Texas had at least one reported case of tuberculosis in 2023. However, the caseload is not equally shared among all our counties. The 10 jurisdictions on the right are the counties with the highest counts of tuberculosis cases in Texas in 2023. So as you can see, these 10 counties alone account for over 67% of all TB cases reported in the state. The data in this slide should not come to you as a surprise. If you recall the list from the previous slide, most of the counties in the top 10 are located in metropolitan areas in the interior of the state. That is, metropolitan areas not located along the Texas border. These are areas like the Houston, the Woodlands metropolitan area, Dallas-Fort Worth, and Austin-Round Rock. Non-metropolitan areas, or our more rural counties, have the lowest number of TB cases. The distribution of TB cases along these non-border metropolitan and non-border non-metropolitan areas align with the distribution of the population in the state. However, when we look at the number of cases in the 32 border counties in Texas, we can see that this region accounts for about 23% of all TB cases in the state. In 2023, 283 TB cases were reported in 13 of the 32 Texas border counties, representing, as I said before, 23% of all TB cases. This is relevant because border counties have a much higher incidence of TB than the rest of the state. Although they represent less than 10% of the state population, about a much higher proportion of our TB cases actually come from the border regions. So moving on, we'll look at the demographics of our TB cases, starting with origin at birth. For the World Health Organization, TB is present in all countries and in all age groups of the world, and there were about 10.6 million people that fell ill to tuberculosis worldwide in 2022. Non-US born persons represented about 72% of all TB cases in the United States in the last 5 years. And in 2023, 67% of Texas TB cases were born outside of the United States. You can also see from this graph here that the proportion of our Texas cases that were born outside of the US has been steadily increasing year after year, except for a slight drop in 2020. Being born outside of the United States in a high incidence country is the biggest risk factor for tuberculosis in Texas. 67% of our patients were non-US born, which is actually, and although this number is quite high, that is actually less than the national average that was 71.4% of US cases were non-US born. So that means that Texas has a higher amount of US-born patients than the national average, which in turn translates to potentially more transmission in our communities. Here on this slide, you can see the top 10 countries of birth among non-US-born cases in Texas. Patients born in Mexico represent the largest group of non-US-born cases in Texas. Together, these 10 countries account for over half of all non-US born cases in our state. About half of foreign-born cases in Texas had been in the United States for at least 5 years prior to diagnosis. To be exact, that was 51.3% of all cases. Those diagnosed within 1 year of arrival represented 30% of our TB cases, and those that had been in the country between 1 to 4 years represented 18.7% of all TB cases in 2023. Looking at race and ethnicity, we can see that when we look at all our TB cases, individuals of Hispanic origin continue to be the largest group among TB cases, followed by non-Hispanic Asians and non-Hispanic African Americans. But if you recall from one of the previous slides, we talked about US-born cases and how Texas has a larger proportion of US-born compared to the rest of the country. So here we look at race ethnicity distribution for US-born cases only. And although Hispanics continue to represent the majority of the cases, we now see that African Americans and whites assume the second and third highest proportion of TB cases. So the distribution of race and ethnicity is very different when we're looking at our population as a whole and when we look at only US-born cases. TB case counts and case rates are higher among men compared to women. The distribution of TB in Texas when it comes to sex at birth is very similar to the national distribution. From this graph, I want you to observe that the incidence rates for males in 2021 and 2022 increased compared to 2020 and are returning to pre-pandemic levels, while the rates for females have remained below pre-pandemic levels through 2022. And 2022 is the last year for which we have rates available. The age distribution for TB cases in Texas has been somewhat stable over the last 5 years, with the group of adults aged 35 to 64 years at diagnosis representing the largest proportion of TB cases year after year. Looking specifically at the year of 2023, adults aged 25 to 64 years represented about 60% of all TB cases. This is similar to the proportions that we have seen through the last 5 years. The group with the lowest number of TB patients were children aged 5 to 14 at diagnosis. In this slide, we are looking at incidence rates for 2021 to 2022, which is the last year for which rates are available, based on the age at diagnosis. We can see here that although most of our cases fall in the group of age 25 to 64 at diagnosis, the burden of tuberculosis is much higher for older adults that were diagnosed with TB at 65 years of age or older. As you can see, the incidence rates for those groups is the highest among all age groups, which means that our oldest Texans are at higher risk of tuberculosis or have higher incidence. Next, we'll look at some important risk factors for tuberculosis disease in Texas. People with medical conditions that weaken the immune system are at higher risk of developing TB disease if infected. Diabetes mellitus was the most commonly reported medical comorbidity among TB cases in Texas. Almost a quarter of our 2023 cases were diabetic at diagnosis. Another important comorbidity is for TB is infection with HIV/AIDS. In 2023, over 5% of all TB cases in Texas were HIV positive at diagnosis. Looking at social risk factors, aside from being born outside of the US, being diagnosed with TB while residing in a correctional facility is the highest social risk factor for TB in Texas. Other significant social risk factors include the use of non-injecting drugs, heavy alcohol use, and experiencing homelessness within 12 months prior to TB diagnosis. These risk factors are behaviors associated with increased risk of transmission and or poor outcomes of treatment. Next, we'll look at the disease presentation among our TB cases in 2023. So as you can see from this graph, the majority, or about 83% of all TB cases in Texas, presented with a respiratory form of TB disease. So that is pulmonary, laryngeal, or pleural tuberculosis. Some important non-respiratory sites include the lymph nodes and, of course, disease of the bone and joints. We now look especially at meningeal tuberculosis that, although does not take a large proportion of our cases, is still a very important presentation of disease, especially among young children. So as you can see here, TB meningitis in Texas is most prevalent among our children diagnosed under 5 years of age. 10 of the 33 children aged 0 to 4 diagnosed with TB in 2023 were reported to have meningeal presentation of TB disease. TB meningitis in children is associated with higher rates of mortality and severe morbidity. We will now look at drug-resistant tuberculosis in Texas. Drug resistance continues to be a challenge in our state. The TB unit monitors closely cases with rifampin resistance or higher order resistance, that is MDR, pre-XDR, and XDR TB. In 2023, the number of drug-resistant cases in these groups overall went down compared to 2022. However, there was a slight increase in the number of MDR TB cases only. Our program continues to closely monitor drug resistance. Now, together with rifampin, isoniazid is another important drug in TB treatment. Although the TB program does not follow INH resistance as closely as it does rifampin resistance and those higher forms of drug-resistant TB, INH is still a very important drug to track. You can see here that resistance to INH changes year to year and has not followed a particular pattern over the last 5 years. For example, in 2022, we saw a sharp decrease in the number of cases reported with INH resistance compared to 2021. And in 2023, we saw again a very sharp increase in the number of INH resistant cases reported compared to the previous year. So we continue to track this and try to identify patterns associated with these ups and downs of INH resistance. All right, last but not least, we will talk about mortalities among our TB cases. Every year, Texans still die due to complications of TB disease or TB treatment. The number of deaths varies year to year. So as you can see, in 2023, we had a sharp decrease in the number of mortalities compared to 2022. The numbers in 2022 were, in fact, much higher than what we saw in 2020 and 2021. We continue to review these mortalities and try to identify opportunities for earlier detection of TB or lessons learned to prevent future deaths. All right, this is my last slide, and here I want to talk about the age distribution for TB-related deaths. So adults aged 45 to 64 years old represented the largest proportion of TB-related deaths in 2023, and they were followed closely by adults aged 65 years or older. And to end on a happier note, I am glad to say that there were no pediatric TB-related deaths reported in 2023. That means that no children aged 0 to 14 years died of TB last year. All right, thank you very much for your time today. That is all I have for you. And if you need any additional information about tuberculosis in Texas, please contact tbepi@dshs.texas.gov. Lauren, back to you.
Thank you so much, Annette, for that wonderful presentation. It's so important that we understand the numbers that are working around us so that way we can go ahead and make better and more informed decisions about our practice. So thank you once again for that. So what I'm going to do is just double check the chat to see if I've got anybody that is asking you a question. I don't think I saw any that went in through the chat, but I will say that you are getting lots of accolades, so congrats there. Let's see. I am not seeing anything just yet. So Annette, if you would just be so kind as to just kind of check the chat, see if there are any questions. Oh, never mind. I do have one. Sylvia Diaz asks, are these active cases? And oh, she also asked if they're latent.
No, all the data presented is for active TB cases.
All right, understood. Thank you so much. And like I was about to say, go ahead and continue to monitor the chat just a little bit in case anybody's got like a burning question that suddenly comes up. Oh, like this one. What about co-infection with HIV prevalence in TB cases?
So I think there was one of the slides in our presentation. We had about 5% or a little over 5% of our cases last year present with HIV infection as well.
Gotcha. Next question comes from Ursilia Bucaria. I sure hope that I'm saying your name correctly. She asks, how do we know patient died due to TB and not other comorbidities such as stroke? Ooh, good question.
All right. So we TB-related deaths are reported based on the official cause of death. So TB has to be listed as either the main cause of death or a contributing factor for the death of that patient. So we work with our programs to review any medical records as well as death certificates to verify if TB was in fact listed as the cause of death or a contributing factor.
All right, and then I have Christine Fletcher who hopped in the chat to ask, can you account for border cases as the index case for U.S. residents?
So we do know that TB incidence is higher along the Texas-Mexico border, and some of it just is associated to the fluidity of TB, people along Texas and Mexico. I cannot, we cannot say with certainty that index cases live in Mexico and come to the U.S., but that is an area with, higher proportion of non-U.S. born individuals and travel, of course, to a more endemic country. TB rates in Mexico are much, much higher than the United States, so there is increased risk of exposure there. But I don't think we can say with certainty that all the exposures happen in Mexico or, in the United States.
All right. Next question comes from Jaquette Germain. Did Texas have any congenital cases?
We have not registered a congenital TB case since 2021, and it is extremely rare. We had a couple cases in 2021, and I don't know when the last time was that we saw one before that. I would have to look at the data, but it is an extremely rare form of tuberculosis, but we have registered that before.
Excellent. Next question comes from Barbara Martinez. Oh, hi, Barbara. She asks, do you think the increase in infant meningitis is related to the impact of TB and the limitation it imposed? She comments, I know a lot of areas were limited on what they could do what they could do face to face.
So the COVID-19 pandemic, I think, affected all TB cases. As far as early diagnosis, children are a group where we usually see earlier diagnosis. Of course, they present with symptoms much earlier than adults. The data we presented here was for 2023, so the pandemic is not much of an impact. I think education and general awareness of tuberculosis among the medical community is a much bigger problem for early diagnosis of tuberculosis.
All right, next question is what was the main NAT implemented in, oh, sorry, actually, I'm getting ahead of myself. Christine asked another question before that. Next question is what type of testing is being done at the border?
So, Christine, if you could clarify that question so I can better answer, but I'll just tell you that IGRAs are the preferred testing method in Texas, and that is what we recommend to all our programs, except for when patients, of course, decline a blood test or for young populations under 2 years of age, where IGRA is not indicated. And those will be tested with a tuberculin skin test.
Next question, the one that I kind of stopped myself with, is what is the main NAT implemented in Texas counties? Is it Gene Expert? And if so, or if it's different, how extended is its coverage?
Okay, I might need help from some of my colleagues here. So Elizabeth, if you're on the call, I would appreciate if you could hop in and help me answer this question. But just while I'm waiting for my colleagues to hop in, NATs are required for patients being managed by our tuberculosis program, by a tuberculosis program funded by DSHS. And Gene Expert is the one that is most commonly used by our programs.
All right, I just wanted to I don't want to get like a false start on anything. Okay, yes, I do have one more question because I was like, I think we covered them all, but let's give like another second or two for a photo finish. Teresa asks, would you know if TB testing prior to school enrollment is required in the metropolitan area? And she also says, great presentation, by the way.
Thank you, Teresa. So that depends on the school districts. We do have the Texas health steps that outline vaccinations and tests that should be done prior to enrollment and what populations should be covered by those. But those decisions are made by the school districts.
All right, I think I'm just reading through some of these last minute things that came through just to make sure if there are any other questions. Oh, yes. Okay, so Rosa asks if TST is recommended for under 2 years of age. Is this very accurate? What if they have BCG?
Although there is some risk of interaction there between the TST test and individuals that vaccinated for BCG, It's still a valid testing method. Children are evaluated more than just a TB test. They do have a physical screening done as well as a chest X-ray. And BCG is not a recommended vaccine in the United States. So for children under 2 that are U.S. born, you are probably not running into that risk of interaction, but I can let one of our physicians from the Heartland SEO TB Center give you some more detail on that aspect.
Next question. Is it necessary to have an IGRA placed if the person tested positive with a PPD placement?
Not necessarily. I think that is at the discretion of the evaluating physician. We do have some guidance for our contracted TB programs on how to proceed with TB evaluation, but I wouldn't say that it is necessary to have an IGRA done for a positive TST.
All right, next question comes from Mario Carranza, Carranza. Again, I'm so sorry if I get anyone's name wrong. I promise I'm trying. Their question is, what percentage of TB cases in Texas move out of the jurisdiction, and what challenges arise from the follow-up?
So unfortunately, I don't have a specific number to give you, but we do have a good proportion of our cases that end up moving within Texas or even out of the state or out of the country. So fortunately, our TB community in the United States has some systems in place that allow for easier tracking. So we have a process called the interjurisdictional notification that is used by all TB programs in the United States. Is a standard form and method of communication that we send to the receiving state with information about that patient, and we are able to communicate with them later for follow-up. And there are mechanisms as well to refer patients to foreign countries and get some information on their treatment completion. So luckily, we have some good systems in place to get that information for patients that move.
Actually, works as a really good transition for the next question from Dr. Luis Arrondo. He asks, does the Department of Health ever give follow-up information to the referring physician?
So that would depend on the local health department that the patient is referred to. Here at the state level, we just get high-level data on the patients, and we compile these aggregate numbers. But specific, medical records and medical information that you should contact your local health department for.
All right. Once again, I don't want to jump the gun too much, but I also know that we're kind of nearing up on the time for our next presenter. So, oh, no, we do have one more question, and this will probably be the last one, guys. And then we have to let Annette go. She does have a life. It comes from Ursilia. How often in the IGN website, oh, no, sorry, let me rephrase. How often is the IGN website updated with accurate staff numbers and contact information?
So the ask of all all TB programs around the country is that every time there is a change in the IGN staff, that the page is updated. So we would send that information to the National TB Association. They manage that website, and they would update the information. Texas, we try to stay on track of that and make sure that our information is up to date, but we cannot control what other states or large cities do, unfortunately. So if you ever run into issues contacting another state or another large city, please let our IGN coordinator know, or contact our TB surveillance team, and they will help you find the correct point of contact. And thank you, Dr. Armitage, for answering those questions, and Rachel as well.
All right, and thank you again, Annette, for taking the time to join us today for our World TB Day webcast. We super appreciate having you. Thank you again for all the wonderful information. Once again, if anybody has any questions, please feel free to drop them in the chat. Annette, I'm just going to ask that you kind of hang around for a little bit, see if anybody has any last-minute questions. But unfortunately, we do need to move on. So we'd love to have you around, but we must share. So take care, Annette. In the meantime, while we get our next speaker prepped and ready to go, I'm going to go ahead and introduce them. That next speaker is going to be the one, the only, Dr. Barbara Seaworth, who is the medical director for our Heartland National TV Center in San Antonio, Texas. So she's rocking it from here. She received her medical degree from Washington University in St. Louis and completed a fellowship in infectious disease at Duke University. She has over 30 years experience with treatment of TB, including complex and multi-drug resistant TB. She serves as an expert TB consultant to the Texas Binational Projects, which occur along the Texas border with Mexico, and is a consultant with the Global TB Network TB Concilium. She is the co-chair for the Community Research Advisory Group for the CDC, which is sponsored by the TB Trial Consortium, is a professor of medicine at University of Texas at Tyler Health Science Center, and is a fellow of Infectious Disease Society of America. In other words, she's amazing. So with that being said, we're going to take a moment or two just to make sure that we've got everything for her all set up. But please go ahead and give me a kind of round of applause for Dr. Seaworth as we get her ready. I do see, Barbara, that slides will be shared. They're going to be published from our training archives, and this entire webcast will also be shared via our official YouTube channel about a week or so from now.
Do they like to see me? They can see me.
Oh, we can hear you, Dr. Seaworth. Yes, guys, there was some slight echo there. Don't worry, it will go away once I mute myself because we happen to be in the same room. But I promise you, that's an us thing. It's not a you thing. So don't worry, it will go away once we get her all properly set up.
No problem.
Yep. Editor mode, presentation mode. So Dr. Seaworth, I believe you're free to go.
Okay, good morning. Thank you, Chelsea and Lauren, for helping me get set up. I'm going to be talking today about the implementation of the treatment programs BPAL and BPAL plus MOXIE in Texas since we have been using them starting in 2021. I want to spend some time telling you about the TB patients that were placed on these two regimens, a little bit about their characteristics. 23 of the individuals were pulmonary TB only, and 9 of the individuals were pulmonary TB plus extrapulmonary TB. The very first case that was treated with the BPAL plus MOXIE was started on therapy in August 3rd, 2021. We had a total of 5 individuals starting in 2021, 16 in 2022, and 11 that we looked at as part of this review from 2023. We wanted to make sure that the ones that we did look at were able to finish therapy in 2023. So there are a number more that aren't included here from last year. If you look at the age of diagnosis of those individuals started on one of these two regimens, only one individual was 17 or less. And part of that is due to the fact that Pretomanid is not yet recommended for use in children under 14 years of age. There were 14 individuals in the 18 to 39 group, 6 in the 40 to 59, 5 in 60 to 70, and then 6 who are 70 or greater who were treated with this regimen. Of those individuals that we looked at, 28 were foreign-born and 4 were born in the United States. But interestingly, 3 of those 4 actually were residing in Mexico during part of the treatment regimen, but then they were U.S. citizens. The countries of birth that were included in those that we treated with this regimen are shown here. Most of them were from, or the greatest number of cases were from Mexico, but we did have a wide variety of countries in which individuals came from. So how did we find MDR-TB and these individuals that we started on one of these two regimens? 23 of them went to a healthcare provider, the health department, the emergency room, or some other provider because of their TB symptoms. 6, however, were found during immigration screening. 2 were found during a contact investigation, and 1 was found during screening of a student at a university level prior to their starting classes. So the types of resistance we saw, 3 individuals were rifampin intolerant, had really serious reactions to rifampin, and so were treated with this regimen. Rifampin monoresistance was present in 7 of the individuals. 4 were fluoroquinolone resistant, 2 had resistant to amikacin, and then 9 had resistance to all 4 first-line drugs. 1 individual was a clinical case, culture negative, the mother of one of these other patients, who did have symptoms and an abnormal chest X-ray, both of which resolved on treatment. Looking at comorbid conditions in the individuals that we treated, 9 had diabetes, 5 were HIV positive, and a number of other problems or challenges that these individuals had are listed here. I'd like to highlight that 5 of them were had spent time in a detention center, and 2 of them were homeless. Some of these detention centers were jails and some were ICE detention centers. And I don't actually have the exact number of who was in a detention center and who was in an actual jail. So if we look at whether their prior treatment for drug-resistant TB, 6 of them had indicated prior treatment for drug-resistant, what either was definitively identified as drug-resistant TB or gave us a history that they were treated with an injectable for an extended period of time in an overseas location, but they couldn't tell us the names of the drugs. You also see that a number were started on RIPE therapy, 10, and then but 22 of them were not started on any kind of standard treatment regimen. And then if we look at the time frame to an appropriate treatment regimen, and that does not mean that they were actually started on B-Pol or B-Pol plus Moxie, but just that they were started on a regimen that was adequate to treat their drug-resistant TB disease. 14 were started within a month, were started in 1 to 3 months, and then 6, it took longer than 3 months to get them started on an appropriate drug-resistant TB regimen. So we, as it's taking longer to get the results from our molecular tests, that is beginning to push back the amount of time it takes to get people started on appropriate therapy. We could previously do that oftentimes within 6 to 10 days, and that's really not possible anymore with the turnaround times for our molecular tests. So these are the treatment regimens that I like to highlight. 8 individuals were treated with B-Pol, but most were treated with B-Palm. Our first line recommendation is for the B-Palm regimen. Remember, 4 people were resistant to fluoroquinolones, so those individuals went to the B-Pol regimen, and then there were some that had toxicities with or wanted to have the smallest number of drugs possible. So they were started on B-Pol alone. 7 people were given what we identified as an adequate bridging regimen to help decrease that time from when patient was identified as drug-resistant TB until when they could gain access to the bedaquiline and the protominid. And I think I'm becoming more and more convinced that we need to get these people on a bridging regimen, and then once we get the molecular tests back, we can start the B-Pol or B-Pol plus Moxie if that's the way we should go, or we can deflect back to the standard RIPE regimen. But I think we can't just leave them without treatment for a number of weeks. So looking at the duration of treatment, most people were treated for 6 months. There were 4 individuals who were treated between 7 and 9 months. Most of those had central nervous system disease. One individual had a really slow clinical response to clinical and radiographic response to therapy. One person refused therapy after 2 months and was not able to be treated any further. And then 3 were lost after 5 months of adequate therapy. And interestingly enough, one of those individuals just popped back up on my desk yesterday. He was in a local jail, and we were identified that he was found. And then one was transferred out to another state, and we have not been able to get information on how they've done since their transfer out. But an IGN was done, and medical information exchanged between the treating physician here, myself, and also the individuals picking up the patient in the other state. So let's look at the time to culture conversion with our new regimens. And if you look at how long it takes to culture convert with a standard rifampin regimen, these numbers are better, but they're small. So we were lucky enough to have 7 people convert their cultures even prior to the BPALM regimen. Remember, we started 7 on an adequate bridging regimen. 7 people converted their cultures within less than 1 month, 3 within less than 2 months, and 1 individual, his first negative culture was exactly at 3 months after the start of the BPALM regimen. So we couldn't determine the timing to culture conversion in 6 of our patients. 1 was a clinical case, so we didn't have culture conversion, and then 2 patients were diagnosed based on expert showing rifampin resistance and a typical clinical case response to therapy, but their culture either could not be obtained for drug susceptibility testing or did not grow. So if we look at medication toxicities, our individuals did really well, and people were screened regularly according to the standard delegation orders in Texas, that they had monthly assessments for toxicity to include visual acuity, Ishihara testing, their EKG, laboratory assessment, a medical assessment, and then a neuropathy screen. And there's a standard neuropathy screen that is done. Linezolid was stopped after month 4 in 1 individual for increasing peripheral neuropathy. Early in therapy, he had very high peak and trough levels, and he also had uncontrolled diabetes and neuropathy at baseline, which did worsen with therapy. EKG, we had 4 individuals that had EKG findings either with a QTC greater than 500. There were 3 of them, and 1 with a 60 unit increase from baseline. All of those individuals were asymptomatic. None had arrhythmias, and none of them really had any other options for what was really significant disease. So treatment was continued. Often the EKG went back to less than 500 or less than the 60 increase. In fact, in all of the individuals, it did on the subsequent EKGs. No vision abnormalities. We had 1 person with a white count that was low in the first month of therapy. Linezolid was held for 2 weeks, successfully rechallenged, and continued throughout the rest of treatment. No hepatotoxicity. We had 2 people with dermatological reactions. 1 developed a brown tongue, which was due to the linezolid, responded to increased oral hygiene, and then 1 had a rash with pretominid, and pretominid had to be stopped, and the person put on an alternative regimen. So if we look, this is just an article looking at the reduced toxicity with intermittent linezolid dosing in combination with bedaquiline and pretominid. There is some data now in mouse models that can be done. So we have been looking at trying very hard to maintain that 600 milligram dose as strongly recommended by the World Health Organization during that first 2 months of therapy. It was also felt to be very important to maintain the linezolid during the initial 2 months of therapy. But then after that time, we will adjust the serum drug levels either to a lower level of a lower dosing level or 600 milligrams 3 times per week. And most patients respond with good levels to one of those maneuvers. So we had our negative outcomes I wanted to share with you. We had 2 deaths attributable to TB. Neither was due to treatment failure. One person had CNS TB that clinically improved at week 3. This woman was discharged from the hospital. She was older. I believe she was in her early 80s. Evaluation showed a fungal sepsis. She had Candida in her blood and her urine. The patient was a poorly controlled diabetic. She had an indwelling Foley for multiple weeks, and then she was on high-dose steroids along with her BPALM regimen and cycloserine for her CNS TB. And we know that both linezolid and moxifloxacin can alter the cutaneous flora and predispose to fungal infections, along with the high-dose steroids, the diabetes, and then the indwelling Foley was likely the source. Her bladder wall was very thickened, and an air in the bladder wall that was likely due to the Candida sepsis that she had. One patient had pulmonary TB and CNS TB and newly diagnosed HIV with a very high viral load, which eventually he was able to clear his sputum, clinically improved, but then developed multiple complications, including iris reactions that were difficult to control, leading to increased intracranial pressure, small bowel obstructions. He received 9 months of therapy, but did die from complications of a small bowel obstruction. That was all part of this larger TB program, so we had to identify that as a negative outcome. I don't think it was related to the treatment regimen he was on, but the underlying disease. So key considerations when we're selecting one of these 2 regimens, one of the first things we need to know is this patient fluoroquinolone resistant? If so, usually we give the BPAL regimen unless we can identify that it's very low level fluoroquinolone resistance, in which case we could use the BPALM regimen with a higher dose of moxi. But for all other patients, the BPALM regimen is believed to be more active based on preliminary information from the TB practical study, and there is nothing yet that is changing that opinion. We need to make sure that we're aware of when these 2 regimens are not recommended or contraindicated. So note here it's central nervous system disease, and that's because they're lacking good data on CNS penetration. There is some new information suggesting that both bedaquiline and protomidate do get into the central nervous system. But when we have used these 2 regimens, one or the other of the regimens with CNS disease, we also always add other drugs to ensure that we have other drugs that also penetrate the central nervous system. Pregnancy, there's just about to begin looking at the use of protomidate in pregnancy, age less than 15. Actually, now it's been age less than 14 and up. But underneath those ages, there's not good evidence that they can be used in kids. Trials are starting that are beginning to look at this, and so I think we'll have more information. It's recommended not to be used in extensive disease or extrapulmonary disease, but those were early recommendations, and there's a wealth of experience in the US and other countries now showing that these regimens are effective, at least in clinical practice in extensive disease. So what's next? Well, we're beginning to see resistance to the current agents across the globe, and a rare case or 2 in the US where they've had increasing MICs to bedaquiline noted. Some parts of the world are seeing resistance rates of 3% or higher to bedaquiline, and also some resistance to linezolid. Those cases of relapse in the US, I'm not aware of all of them, but certainly aware that there are some, and I've been involved in discussions on a couple of them. But this highlights the importance of following up our patients after treatment completion. And we don't really have much information on what's happened to these individuals after they've completed therapy. We assume we would be contacted if you were having relapse, that we would be notified by either the program or the state, but we don't have the information showing what's happened to the CT scan, the chest x-ray, the patient's weight, their clinical condition, and their x-rays after completion. So we're going to be reaching out to the TB programs to try to find that information. If you look at what's happening in the research studies, many new drugs, many new regimens are out there and being studied. 2 new regimens have had reported results now, and so we're going to be getting more options. And as resistance and toxicity occurs, that things are likely to become more complicated again with not just 1 or 2 regimens to choose, but a number of different options. However, we noted that there's been major benefits to our patients to have access to these shorter, more effective, and less toxic regimens. So I want to thank all of the patients that were working with us during their treatment, all the nurses and physicians that have shared their cases with us and asked our opinions, and to our partners at state and local health departments who have helped us to have access to the information we needed to provide consultation. So a big round of thank you all around, and this is my last slide. Thanks.
Thank you so much, Dr. Seaworth. I'm looking through the chat to see if we have any questions. I'm trying to speak a little quieter so that way we don't have the feedback loop going on from before. So sorry if I sound like I've just gone into National Public Broadcast Radio voice for a moment. No, Dr. Seaworth, you're fine. All right. So it looks like we have a question from Candace Atkins. She says, I may have missed this, but can you provide an example of a bridging regimen?
So what I think is a reasonable bridging regimen, and again, it depends if patient's in hospital and how sick the patient is, and then what we might know about the likelihood of drug resistance in these individuals. For instance, if we think that this patient is likely to have a false positive gene expert, in other words, probe B drops out. That's why we're always trying to find out what probe dropped out. And if we're working with a private lab, often we can't find that out. But if we're working with a state health lab, and we've had a couple patients now who are part of a cluster in the southeastern part of our state where they have INH resistant disease and false rifampin resistance. I'm aware of, I think, 3 or 4 individuals. I would go ahead and start rifampin on those individuals, PZA, and then linezolid and moxifloxacin. So I have at least 2 new drugs and 2 other drugs I think are going to work. If the individual is from along the border, there's a very high possibility they're resistant to all 4 first-line drugs. And so I'm not going to be as anxious to start one of the first-line drugs. I would, in a difficult patient like that, I would start linezolid, moxifloxacin. If I can get access to cycloserine, if patient is in the hospital and very sick, we've used a bridging regimen with an injectable amikacin for a couple weeks IV. And then we've also used meropenem with clavulanic acid for people who are really ill. I don't like to start something like ethianamide, which will probably make the person vomit, not be able to take their other medicines, and is a very weak drug. So if we have access to clofazimine, which we do in the state of Texas, but usually it takes a while to get it, clofazimine may be another option. But I think at least having 3 bactericidal drugs available, and you can get that with moxifenazolid and cycloserine for the vast majority of your patients, adding PZA for an outpatient, and then an injectable or meropenem for an inpatient, and then hopefully while we're waiting for the molecular test to come back. We have had some times when it's taking 10 days, but over the holidays, or if there's a mix-up with getting access to the shipment over there, there's weather. I mean, we've had patients that it's been over 2 weeks. Be really nice to have access to molecular testing in the state. Just a plug for that, but I don't know if that's possible. But many states and big cities now have access to molecular testing within their particular region, so they're not dependent on whatever's happening at the CDC. And we certainly have a number of drug-resistant patients and challenges within our state.
All right, I have another question from Rosa. She asks, if they have INH resistance, what do you recommend?
So the recommendations, the current recommendations from the CDC and from the World Health Organization is there's isoniazid resistance. The first thing I'm going to ask the lab to do, or the program to do, is get with the lab and make sure that patient has fluoroquinolone susceptibility testing. Just got a consult back that I asked, and the program, was working with the state. The lab did have the culture, but only for genotyping. They ran the susceptibility and found out it was fluoroquinolone resistant. So obviously there's a different plan there, but if the patient is fluoroquinolone susceptible, I will use rifampin, PZA, fluoroquinolone, and ethambutol for 6 months. That is the recommendation. Now, there is some leeway there if the patient is having a challenge with tolerating PZA later in therapy. In many patients, you may be able to stop the PZA, but you definitely need the fluoroquinolone and the rifampin for an entire 6 weeks. So the clock starts counting when you add the fluoroquinolone.
All right, I got a 2-pronged question from Dr. Kizelbosch, our next door neighbor. She says, excellent presentation, Dr. Seaworth. 1, how many patients with CNS TB have you treated with BPALM and an additional drug such as cycloserine? And then part 2 of that question was the duration 9 months or longer?
So the second part is easier, and I think the answer to that is 9 months, maybe longer, depending on how the patient responds. Within this group that we looked at now, there were 4, and I don't know how many, but we've seemed to have had a run of CNS tuberculosis lately in adults, and we have several individuals, it might be 4 or 5, that are also on treatment now that were started in later 2023 or early 2024. So we're trying to look at how many cases of TB meningitis, because it may not be something that is identified right away when a program, puts in their TB 340, and it might not get checked on the box, because I think we're seeing more than what gets reported back to the state health department, because it may take a 3 weeks to a month or so to identify that CNS TB.
Next question comes from Megan Newton. She asks, what if the INH resistant person is still culture positive at 2 months with cavitation? Would you extend treatment beyond 6 months?
Yeah, so looking at 2 months, and there's 2 months of a fluoroquinolone containing regimen, I would probably extend, yes.
All right, it doesn't seem as though we have any other questions just yet, so I'm going to give it like a quick little second or two to see if any do come in. But in the meantime, thank you so much, Dr. Seward, for your time and for giving us all this excellent information regarding the BPALM regimen throughout Texas. I'm sure it was quite enlightening for some of our guests right here, and I'm seeing lots of reactions in the Microsoft Teams chat, so everyone loves it. So thank you so much.
All right, thank you. We hope to get some more follow-up information and share that with all of you later. Thank you.
Yes. So Dr. Seaworth, if you would be so kind as to mute that station right there so I'm not accidentally blowing out people's eardrums with feedback, that would be great. And in the meantime, I'm going to invite Dr. Yamba to go ahead and try to present her screen while I go ahead and introduce her. We are having some slight technical issues that we're trying to resolve, so we just want to make sure that she has the ability to do that. So in the meantime, while we try to get that part going, I'm going to go ahead and take a moment to introduce Dr. Yamba. So she is the TB physician consultant for the Tuberculosis and Hansen's Disease program and binational TB program. Dr. Yamba has gained practical experience in the field of TB. In this role, she has been providing medical consultation to local and regional TB programs, as well as the binational TB program, working closely with the TB clinical care team. During her time with the Texas Department of State Health Services, she had the opportunity of presenting on various aspects of TB at numerous meetings and conferences where she shared insights on and updates on TB. And then following with her, sharing this time, is going to be Dr. Armitage. Now, Dr. Armitage will have her own presentation going on later as well, but she's also going to be tag teaming with Dr. Yamba for this next presentation. So just real fast, Dr. Armitage is also one of our heroes here at Heartland National TB Center. She is a board-certified infectious disease physician and is board-certified in internal medicine and pediatrics. She loves her little people. She has worked for several years in the field of TB and serves as co-medical director for Heartland National TB Center. She obtained her PhD in molecular pathology and is currently involved in clinical research to improve treatment outcomes of TB patients. So I'm going to get both these ladies set up, but Dr. Yamba, are you able to unmute yourself and join us?
Yes.
Excellent.
You don't see my camera, no?
Oh, I do. Yes, I see you.
Okay.
All right, so I'm going to spotlight you for everyone just to make
but
sure.
I cannot share my slide, unfortunately.
There you go.
Maybe you need to pin me as a presenter so I can be able to share my screen. If not, you can help me.
Yes, ma'am. So since we're having difficulties with promoting you, I'm going to go ahead and share the screen. And then Dr. Yamba, just let me know when you want me to advance your slides, and I will be happy to do so, ma'am.
Okay, thank you.
You're quite welcome.
All right. Good morning, everyone. Can you hear me well?
They should, yes.
Okay, cool. Yes, thank you. So I am Lana Yamba. I am the TB physician for Public Health Region 11, based on, in Harlingen office. So next slide. Today, I want to share a case of a 2-year-old child who was referred to us for a better management of TB meningitis. The child first presented to the ER on April the 6th, 2023, due to worsening high stool burden for 2 weeks. An enema was given for constipation, and the patient was discharged home the same day. So before to that ER visit, the patient had been seen by the pediatrician multiple times for the same complaint of constipation and flu-like symptoms. Then on April the 9th, a few days later, the patient was brought back to the ER due to altered mental status, increased fasciness, vomiting, poor intake, and ataxia. Upon admission, a CT of the head revealed hydrocephalus. Then the child was taken to the operating room and an external ventricular drainage was placed. Next slide. An MRI of the brain and spine conducted April 10 revealed an extensive leptomeningeal enhancement in both brain and spine, suggesting an infectious meningitis. So this possibility of meningeal neoplastic dissemination was also considered due to the thoracic lesion. A chest X-ray done April 9 showed a perihilar bronchovascular prominence, suggesting an infectious bronchiolitis. So the CT of the chest, abdomen, and pelvis was also conducted on the 11th, and it showed a mediastinal mass, raising concern for various conditions such as tuberculosis, fungal infection, as well and metastatic carcinoma and or lymphoma. Next slide, please. All right. So on this slide, as you can see, we have some few slides of the brain. I won't go into specifics, and then apologize if the slides are not clear enough. So let's go to the next slide. Lab results. T-spot tests done on April 10 and 13 were both negative, as was the PPD test. Various panels were done, including the meningitis, encephalitis panel, PCR, respiratory panel, carriers, and blood cultures were also done, and all were negative. However, the CSF results showed a normal glucose level at 52 with elevated protein at 113, RBC 325, WBC 23, neutrophil count was elevated at 25, and lymphocyte count was low at 39. So all these findings were indicative of bacterial infection, including TB meningitis. Next slide, please. Based on the CSF result and MRI findings, a non-empiric TB treatment was started at the hospital with rifampin 10 mg per kilo, INH 190, PZA 440, EMB 260, and prednisone 1 mg per kilo. So after the health department evaluated the patient, the staff was able to collect tracheal aspirate and speedoms. I didn't mention that in this slide because I have updated my slide that Lauren doesn't have. So the tracheal aspirate and the speedom came back smear positive and culture positive for MTB, not positive. Then a consultation request was submitted to Heartland for medication adjustment, and the adjusted medication regimen included INH 200 mg daily. We increased the rifampin to 300 mg daily. We added levo on the regimen. The PZA was increased to 500, and prednisone was increased to 1.5 mg per kilo to reduce inflammation and reduce any potential complication. The EMB was discontinued as EMB has poor penetration into the brain. I just want also to mention that a contact investigation was conducted and no source case was identified, unfortunately. Next slide, please. Follow-up assessment. The treatment was started April 25, 2023. So the child is now 11 months into treatment, and she's doing very well. Her condition has been improving with PT. She's able to use the right side of her body. She can now walk again with the assistance of leg braces. She has recently passed her swallow study, but still takes her medication via PET tube. She has become very vocal, and she's working with the speech therapy to improve her speech. In 2023, we had a back-to-back, especially the first year of the first half of the year 2023, we had back-to-back TB meningitis cases, which raised concern. So we worked with Heartland to develop a TB meningitis poster, and we have the link here. And on the next slide, that's the poster that we created. Next slide, please. So this is the poster, and then it is now published on the Heartland website. So that's the poster that we are using to spread the knowledge about TB meningitis with our community providers. And so thanks to the work of with Heartland, and so this will be the end of my presentation. So Lauren, I will, yeah. Yes, thank you so much.
Thank you so much, Dr. Yamba. I do believe that Dr. Armitage is ready, if I'm not mistaken.
I think I'm ready.
Yeah, there you are. Go for it.
Okay. All right. Can you see my slides, Miss Lauren?
Yes, I can.
All right. So I'm going to pick up where Dr. Yamba left off, which is, describing our baby. And I just want to give some kudos for her recognizing a real need in her community and reaching out to us for something that we could do to address that. So I wanted to walk through the components of the poster first. So it looks like, if I go back one, it's like one big poster. It's a whole bunch of information, but it's really just everything that we do and everything we know into one tight place that you can present if you need some help in your community. So starting off with the risk factors, the ones that are most obvious: immune compromised individuals, and then close contacts to individuals with infectious TB. I want to remind y'all that the contact investigators on the call, appreciate y'all, but we all know that if you look in the household of someone with active disease, about 30% of people in that house will already have TB infection. They will be infected in what we call LTBI, and 1 to 3% will already have progressed to active disease. So for children, they don't go to work. They don't complain of headache. They don't take sick days. Sometimes they're out of school, but really small children especially, that is the money shot for getting your babies identified. There's no other reason they have no contact with the world except for you to come into that house and see that there's a small child in there that needs to be evaluated. So looking at the age of the ages where we see that there's a problem, we divided them into less than 1 and then 1 year old. So if you are infected with tuberculosis and you're between the ages of 1 year and at birth and 1 year, in that first year of your life, you get infected, you have almost a 50-50 chance you're going to advance to active TB. And if you're between 1 and 5 year olds, you have a 24% chance. So why are we always so aggressive about getting in there and getting the children under 5 evaluated, getting the children under 5, 5 and under evaluated, 5 and under, tested and started on winter prophylaxis if necessary, because their risk is the highest. So with an immune compromise, you're just looking at HIV infected individuals, 30 to 50% lifetime chance of advancing to active disease is very similar to what we see in babies and young toddlers. Now, next we're looking at foreign-born. So the word foreign-born kind of has a two-prong deal. So if you have children who are coming from high-risk countries, you see that they are at increased risk for having tuberculosis. But when you look at the actual numbers from the CDC, U.S.-born children in our cases of children in the U.S., it's U.S.-born children. Well, that also has the caveat that these are mostly U.S.-born children with non-U.S.-born parents. My parents are from, up near Waco and up near Huntsville, and we still go there. If my parents were from Mexico, we would go there. If my parents were from Pakistan, we would have visited there. That's where our family is. So in the, having children that are actually, moving about, but also who are from places with high risk, but also going into places with high risk. I want to throw one little nugget in here. And if anybody knows it to be different, please put it in the chat box. But my understanding is that with the current BCG shortage worldwide, if a child is born in the US and they're taken back to Mexico, that child will not be. Somebody's talking. Okay, sorry. If that child is taken back, if is born in the U.S. and taken back to Mexico, they will not be BCG vaccinated. So that is a big thing. BCG reduces the risk of severe disease, meaning disseminated disease, TB meningitis in children by 70 to 80%. So when you have children who are born here in the US and taken to a country where they are not vaccinated, that is a very high risk. So that, another point to consider. Now, let's talk about the treatment outcomes. We say in our poster, on average, 54% of children who survive TB meningitis will develop neurologic sequelae. So this is just one meta-analysis of a systematic review and meta-analysis that was published in the Lancet Infectious Diseases. 19 studies, over 1,600 children, the risk of death 1 in 5. And that's incredible. You can't think of anything that would kill 1 in 5 children if they had it. Not car accidents, not, mere drownings, but risk of death 1 in 5. The probability of surviving without any neurologic problems is less than 40%. So the risk of neurologic sequelae, well over 50%. And then diagnosis at stage 3, 47%, it is when 47% of children are diagnosed at stage 3. I'm going to walk you through the stages of and the outcomes next. So when we're trying to improve outcomes, we know that prompt diagnosis and treatment is essential. So failure to begin treatment swiftly results in poor outcomes, significant and permanent neurologic sequelae, or death. So stage 1, this is where we're living. Unfortunately, notoriously nonspecific. They can have cough, low-grade fever, vomiting, general listlessness. The most valuable findings are persistence of a nonspecific symptom. This baby kept going to the ER with complaints of constipation, but also flu-like symptoms. And then she developed a cough. Weight loss, recent contact with an active TB case. We didn't have that with this baby, but if you have if you identify an active case of TB in the realm of a child, you have a 70-80% chance of actually making a diagnosis of TB meningitis before that child is impacted by it. When we move to stage 2, this is meningeal irritation. This is when the child is starting to act a little bit different. Other neurologic signs, loss of consciousness, signs of raised intracranial pressure. When you see deviation of the eyes, paralysis. Stage 3, deep coma, progressive motor paralysis, cranial nerve palsies. You lift the eyelids up, and the eyes are going in different directions, and decerebration. So this is really where you have a child lying stiff, and the arms are twisting inward, basically, or pronating. So that's when the wheels have really come off. Down at the bottom, so the British Medical Research Council has their clinical criterion for TB meningitis. This is really an adult or a child based classification. The classic classifications, basically in stage 1, fully conscious with no neurologic deficits. These are the ones when you're starting to see that they have some of that cough, low-grade fever, some vomiting, maybe a little fussy, but no focal findings. Second, they're conscious, but they have inattention, confusion, lethargy, and focal neurologic signs. Now you're starting to see maybe some mild twitching or some other, like this baby couldn't stand. And then by step 3, stuporous or comatose, multiple cranial nerve palsies, or complete hemiparalysis or paralysis. And this is usually because there's inflammation of the vessels in the brain, and they've, because of that, occluded and caused a stroke. Contemporary criterion now just use the Glasgow scale, so that physicians in the ER can measure, on a Glasgow scale, something a little bit more objective and give them a rating so you can see if a child is improving or deteriorating. But if you look at the risk of death, the risk of death, if you are HIV negative, is 15% in stage 1, progressed to 30%, so that's 1 in 3 in stage 2, and 50% in stage 3. So, you know, the baby that was described by Dr. Yamba, really, literally, she's at the point where we got the hemiparesis, we got paralysis, we have cranial nerve palsies, seizures. She had a 50% chance of death and almost 0% chance she was going to survive without any neurologic findings. If you look at the numbers for HIV infected individuals, 25%, you know, of risk of death. So 1 in 4 already, even when you catch them early, 50% at stage 2 and 80% at stage 3. So now, watching for signs and symptoms. Stage 1, like I said, is when you want to diagnose. This is a notoriously nonspecific time. Again, cough, low-grade fever, vomiting, general listlessness, multiple visits to the pediatricians. Trying to get the word out to the pediatricians what you're looking for. If you're, you know, if you got a kid that keeps showing up, what is it that I'm looking for? What am I looking for? What is it that I'm trying to find? If you had just getting them in their gut to know that if they have a kid that keeps showing up with nonspecific symptoms, maybe they need to look in this direction. The most valuable findings, again, persistence of nonspecific signs and symptoms. So clinical presentation, children with TB meningitis tend to develop meningitis within 3 months of infection. So within 3 months of inhaling that organism, 75% will present within 12 months of infection, so very early. So the pace of infection is usually rapid, weeks to months after infection instead of months to years like you see in adults. Children have a headache less frequently than adults do, so that's not something they're going to complain of. I was taught in medical school that when a person explains to you that they are having the worst headache of their life, meningitis in general shoots to the top of your list. That's not something you're going to be seeing here. A 1-year-old complaining of a headache never has happened. So in small children, TB meningitis is very closely associated with disseminated disease. Makes sense. If it disseminates, if it's in more than one place, then that means that the TB has hit the bloodstream and has hit a lot of different places it could be. So the recommendation to do an LP on all children less than 12 months of age with active disease is based on this association. So when we tell you to send a baby in to be evaluated, let them know that your expectation is you have evidence of active disease, the child is under 12 months of age, and you want an LP done. So clinical presentation at diagnosis is the strongest predictor of outcome. So again, if you're getting him in stage 1, highest chance of having a good outcome. Stage 3 is the lowest. And in the meta-analysis, fever, 89.9% of children with TB meningitis had fever. So persistent fever, again, very high on the list of things that you're looking for. I thought this was a really good, this just a really good basic piece of knowledge. And this came out of the guidance for national programs, put out by the World Health Organizations. And for TB, it's hard to diagnose in children. We don't have our test, haven't kept up with what our needs are. A really astute physician is still the best tool that you have for diagnosis, but they state under symptoms, in most cases, children with symptomatic TB develop chronic unremitting symptoms. For example, symptoms that persist more than 2 weeks without sustained improvement or resolution following appropriate treatment for other diagnoses. For example, antibiotics for pneumonia, antimalarials for fever, nutritional support for failure to thrive. So you've given the appropriate treatment for what other things it could be. Community-acquired pneumonia here in the U.S., an ear infection, otitis media. You've given all of those, and the child still has cough or fever or not eating well, anorexia, weight loss, failure to thrive, fatigue, reduced playfulness. Children play. That's what they do. They play, and they are active. So when you have a child who is not, then again, TB needs to be on the top of the list, but you're looking beyond that for evidence of TB meningitis. So medical assessments, most of our tools do not help us out. So sensitivity of the AFB stains, about 10 to 20%. I love this. You get a large volume tap. So you imagine my 6-month-old patient that I'm suspicious, has TB, and I want to get a 10 mils of CSF, which I don't know, for me, just feels like the whole volume of that baby CSF. Spin it, and then I want an experienced microbiologist to spend 30 minutes examining that slide, and I can get the sensitivity up to 80%. So in the perfect world, that is exactly what would happen. In the real world, probably not. Culture is more sensitive, but it's not timely enough to make a decision. If you call me and say that the smear is negative, the cultures are pending, but they're negative, and you want to stop treatment, my head's going to pop off. Okay. Gene, it takes for the, in general, you have very few organisms. If you don't see them, it's going to take longer to grow them. And so you're looking at maybe 4 to 6 weeks to grow. If after 4 to 6 weeks of TB ravaging a young brain, not a lot's good is gonna happen. So you need to start treatment faster than that. A meta-analysis of 30 studies did find that there is about an 81 to 85% sensitivity if you use GeneXpert, but this was enhanced by a large volume tap, and you have to centrifuge the specimen. Distressingly, the TST and IGRA in 22% of cases is negative at diagnosis. And that is exactly what Dr. Yama's patient showed. So you should consider doing both. If you haven't determined a diagnosis and you still have some concerns, really consider doing both tests if you're testing at all. So typical CSF findings, usually lymphocytes. In the first 10 days, you can have polymorphonucleocytes, but when you do that tap, most of the cells you're going to see are going to be lymphocytes. And then you have elevated protein, which you saw, and decreased glucose. So while Dr. Yama's patient did not have, her glucose in her CSF was normal, it was still on the low end of the scale of normal. Because I remember looking at that because I looked at her numbers, and I think the cut point was about 50 or maybe 45. So on the lower end of the normal scale. But in laboratory findings in peripheral blood, leukocytosis, so high white blood cell count, was seen in almost 100% of the patients that had TB meningitis in this review. The CSF lymphocytes, about 98%. But look, AFB smear positivity, 8.9%. So when you have someone trying to explain to you why they don't think that's it, because the AFB smear is negative, you have about an 8.9% chance looking, globally, that you're going to see that. And then culture positivity is still low at about 35%. CT or MRI with contrast? The answer is MRI with contrast. A CT with contrast is good if you're looking for a bleed, or if you're looking for a broken bone, or if you're looking maybe even for mastoiditis. So if there's anything associated with the bone or blood in the brain, yes. But if you're looking for meningitis, an MRI with contrast. And if they send you a CT scan, smile real nice and say, I need an MRI with contrast. So basilar enhancement, that's the base part of the brain where all of the cranial nerves live. So when you get a lot of inflammation going on down there, that's inflaming a whole, but just think all 12 cranial nerves are coming off the brain, and you're touching everything. Hydrocephalus in about 87% of children compared to only 12% in adults. So if you get a scan and it shows hydrocephalus, game on, you're looking for it. Infarcts, unfortunately, 28% of patients, so nearly a third of babies, somewhere between 1 in 4 and 1 in 3 babies with meningitis are going to have a stroke. And it's usually in the middle cerebral artery distribution. And what happens is you get inflammation of that vessel, and it occludes shut, and it shuts down off the flow downstream. And then tuberculomas, these are basically like, nodules in the brain with that can contain TB. And the contrast will highlight the ring enhancement. So you actually will see the lesions better if you do the CT. If you do the MRI with contrast, the contrast will actually highlight those lesions for you. So remember, from this slide, MRI with contrast. Now, window prophylaxis. A big part of preventing all of this is basically when you're doing your contact investigation, finding the little ones in the house. So if you have a household contact to a contagious person, usually a teen or an adult with pulmonary TB disease, usually greater than 4 hours of contact. Said this before, if you have somebody who is holding a small baby, that usually is a two-hand operation. And so you're in the airspace very intensely of that baby, especially if the source is coughing. If you have done an initial TST at IGRA and they're negative, so this is, the window period for TST conversion is 8 to 10 weeks. So this is at the beginning of your investigations. The chest x-ray and the physical exam are normal. A child who is coughing, that is not a normal exam. A chest x-ray that shows parahilar or parabronchial, infiltrates is not a normal chest x-ray. You need to follow that child a little while and make sure those things are normal, and you don't need to start 4 drugs instead of window prophylaxis. So window prophylaxis is recommended for children less than 5. Always the question is greater than 4? Is it 4 or less? When you hit 5 candles on your birthday cake, your immune system should be acting more like an adult. So at that point, you would screen like you would all of the other household contacts who are adults. But if you have not hit 5 candles on your birthday cake, then window prophylaxis need to be considered. Immune compromised patients, all of them at every age. Patients on tumor necrosis factor alpha blockers or any other of the biologics also need to be considered, because they may not give you a positive TST, even though they have inhaled the organism, because their immune system has been suppressed. So you can prevent progression to disease during the window period by adding treatment. So you want to repeat the TST 8 to 10 weeks after exposure. And then if the second TST or IGRA is negative in immune competent patients, you can stop. But this is, again, besides just finding these children, it is life-saving to be able to start them on treatment before they turn into your patient. Now, I didn't share this with Dr. Yama, but I wanted to add in, this patient had a 5-month-old sister. So the patient's 5-month-old sister was being evaluated as part of a source case investigation. So now we have a 2-year-old, and they never found a source case, but they went into the house looking for one. So the health department was on their job. Initially, her chest x-ray was negative and she had no symptoms. So she was just going to be referred into the health department to start on window prophylaxis. But 1 week later, she had a cough and an abnormal chest x-ray. So I swear, the story I heard was that the nurse was in that house, heard that cough, and sent that baby in for further evaluation. And she produced an abnormal chest x-ray now and symptoms. So because she's under a year of age and they're suspecting active disease, they insisted on an LP, yay. And she had elevated white blood cell counts. You only get 0 to 5 in the CSF. She had 54. Now, it was a bloody tap, so I rounded down and I would say 50, but that was as many as I felt like I needed to round down. She had elevated protein at 68, and she had a normal glucose, a normal, CSF glucose, but it was on the low end of the normal range, like her little sister was, and her serum glucose was way up almost 80. So after all of this evaluation, the treating physician wanted to treat her for LTBI. I have to tell you, I went through all the feels. First, I was incredulous. Second, I just about lost my mind. And then third, I thought of some evil thoughts. So I wanted to put the cuss mouth emoji on here, but Hal told me no. So after all the feels, I had a discussion with the doctor and I said, "Doctor, this baby has clearly meningitis. She has 50 white blood cells." And I'm thinking, stage 1, we jump in there early. This baby's going to be okay. This is one of our success stories. And he said, "Yeah, but she looks beautiful. I'm looking at her." I said, "Look at what the number said." And he's like, "I am, but I'm looking at her and she looks great." And I said to him, "Do you want to wait until this baby?" I said, "I just got consulted on a baby who had a stroke. Do you want to wait until she does that?" And he goes, "Ooh, no, I saw that baby." So Dr. Yama and I have been down to work, but I wanted to throw this in. This is from the email Dr. Yama sent me after I spoke to that physician. She said, "I'm really grateful to Bella, Cameron County nurse, who was proactive and consulted with you on this case. The hospital was about to start the baby on prophylactic treatment, despite the CSF result, the history of a sibling with TB meningitis, and current signs and symptoms, and a recent abnormal chest x-ray. And the reason I bring this up is because, there are about, hundreds of Bellas out there. All of y'all, what you do every day, to protect our patients, to make our patients better, to advocate. It's the advocacy that is so important, and that makes each and every one of y'all who are on this call right now so special. So I just wanted to take a minute to give a shout out to each of y'all for everything that you do every day to make things better. But some take-home points: TB meningitis is unique in children in that the brain is in the process of developing. So not only now you have an infection that's trying to derail things, but this is a brain that's trying to grow. Early diagnosis is critical. I mean, I can just stop right there and put a period. It is critical to prevent morbidity. It is critical to prevent deaths, but unfortunately, most diagnoses are made late, and this has to change. So that was part of us bringing forth the product. Hopefully you can go out and evangelize with it, but we have to do some things different. But more studies are needed in children to maximize outcomes, everything from diagnosis to treatment. And that is all I have to say. So, Lauren, I'm going to stop sharing.
All right, I do have a couple of questions that have arrived in the chat. Some have already been answered by many of our friends and some of us here at Heartland. So I'm going to go with the ones that have not already been answered just yet. Dr. Yamba, you would probably know this best. Teresa asked, did they ever pinpoint where or how the 2-year-old was initially infected? Oh, Dr. Yamba, you're muted.
Yeah. So actually, we did not find how the child was infected. So we expanded even the contact investigation. So all the family member, grandmother, uncle, other siblings, and even friends that frequently visit the family, nobody tested positive. But I'm sure sometimes somebody came in contact with the child, maybe, and the child wasn't going to school and neither to a daycare. So it means he was in contact to a TB case, but we never found the source. And the mother denied any history of travel to Mexico. So probably we won't know how the child was exposed to a TB case, unfortunately.
It seems like there was some speculation going on, because I do have a person in the chat asking, was this child foreign-born or did she have foreign-born parents?
The child is a U.S. born and the parents are foreign born. So, yeah.
Yeah, they took the baby to Mexico, though, at some point, right? She had not been over there yet, though?
No, I think, yeah, they did took the child to Mexico. Yeah, now I remember. Yeah, they did. Yeah, just for a vacation for just a few weeks during the summer.
And then I think one final question that we have before we have to move on for the sake of time is asking about PCR for children. It literally, the question is, what about PCR for children? Question mark.
Absolutely. PCR, TSTs, IGRA, every test you have, throw it at them. Unfortunately, the sensitivity for the IGRAs is higher. So we try to, any specimen that you get out of a child, I would try to at least advocate for having it tested by an IGRA. Like I said, the culture is probably the most sensitive, but it takes a really long time for it to grow and it's not helpful. But if you get a specimen out of a child, I would definitely be advocating for an IGRA. I mean, I'm sorry, for a NAT, for an expert. Yeah. Or PCR, whatever test they have that fits that category, I would be asking for it.
Well, thank you so much, ladies. I do have a couple other questions that are in the chat, but I'm sure that you could probably echo what I'm about to say to them. One question is, where on the Heartland website can we get the kids' TB testing informatic? It is on our products page from our official website. And then there was a follow-up question that was asking about suggestions on how to administer meds to babies. There's also a product for that, also on our Heartland TB website. Right. But I'm sure that, ladies, if you have any other tips or tricks or magic wands that you could wave in response to that question. I'm going to invite you to feel free to respond to Ann Rickard, because she would very much like to know. I'm sure, as do we all. Don't get Dr. Armitage going on the European
I'm going to defer to the Heartland nurses. Everything I've learned about how to get medications into a hostile toddler, you know, it's like worse than negotiating with terrorists and those little kids. But everything I've learned, I've gotten from the nurses. So I'm going to defer to them. They have some really good tips.
Yes.
But, and also before we kick off, I just want to, this is my second time partnering with Dr. Yamba. I just want to say, you know, how great it is not only to partner with her on this talk, but I mean, really her advocacy for this baby, for both the 2-year-old and the 5-month-old. And the nurses who are really, you know, going after it, trying to make sure that things get done. I'm telling you that when you have a toddler who had a stroke and who should not, you know, by any means walk or talk, and to hear that she's walking and talking, and the 5-month-old is now talking, and now they're probably fighting because they're sisters, and it's awesome.
Yeah. Thank you.
No, thank you, ladies. Thank you so much for your time today and for giving us some excellent knowledge that is so needed. So I'm going to go ahead and just invite you ladies to answer some questions that I see have popped up in the chat. But in the meantime, I'm going to go ahead and introduce our next speaker. This is Dr. Cruz is going to be coming up on deck. So let me take a little time to introduce Dr. Cruz to you all. She is a professor of pediatrics at Baylor College of Medicine in Houston. She completed fellowships in pediatric infectious diseases and pediatric emergency medicine at Baylor, and she has a master's of public health in epidemiology and global health at the University of Texas. She is an associate editor for pediatrics and has almost 200 publications under her name. She serves as a pediatric TB consultant to Heartland National TB Center and has assisted the Centers for, the CDC and the WHO with pediatric TB guidelines. Her other research interest is in facilitating the diagnosis of infectious diseases in the emergency department. So everyone, take a quick little moment to welcome Dr. Cruz on board. Hi, Dr. Cruz.
Hey, good morning. Can you guys hear me okay? All right, perfect. I'm actually having issues with the sharing screen. Oh, thank goodness you're here. Okay, hold on a second. Give us a second, guys, because I am very accustomed to Zoom and less accustomed to Teams. Is that better? There you go. Excellent. All right. Take it away, Dr. All right, thank you guys so much. In 4 years into the pandemic, I'm still unaccustomed to doing virtual meetings. So thank you so much for your time. I do have a couple disclosures, and neither of which are actually relevant to this talk. And I have a couple acknowledgements. The first is that I'd like to acknowledge one of my colleagues, Sylvia Chang, who's really been instrumental in sort of fleshing out the role that the impact of sort of emotional and mental health problems in adolescents, specifically who have tuberculosis. And lastly, my patients really from whom I've learned so much. In the course of the next 45 minutes or so, and I will leave time for questions, we really have three objectives. The first is to identify common mental health considerations in our adolescents, understand validated tools to screen patients should concerns arise, and then identify strategies to make TB care easier for adolescents. So in terms of adolescent TB epidemiology, this has very much been a moving target over the last couple of years. And the reason is this. So the World Health Organization actually defines adolescence using chronological outcomes. So they say if you're 10 to 19 years of age, you're considered an adolescent, and they consider young adults to be 20 to 24. So what is a problem from this, aside from the fact that dealing with a 10-year-old is substantively different than dealing with a 19-year-old? It's different in terms of emotional and physical development, et cetera. So from the standpoint of putting on my pediatrics hat, what we always say is that adolescence really begins with the onset of puberty, and we know there's already a lot of variation in that, and ends with your transition to adult life. And considering the number of kids who graduate from college and move right back in with their parents, you could definitely make the argument that that endpoint is quite variable and might extend well beyond the mid-20s for many of the patients. Part of the other issue, frankly, from a TB reporting standpoint, is that for a long time, and WHO continues to define a child as someone who's less than 15 years of age. which means that the younger adolescents were all getting lumped in with the pediatric data. They were getting lumped in with, some of the kids that Lisa just told you about. And then the older patients, the older adolescents were actually getting lumped in with adults, right? So, the degree to which a 17-year-old and a 71-year-old should really be categorized in the same way, obviously very much up for debate. This doesn't just extend to reporting, it extends to adolescent-specific guidelines. So, for example, we know that just looking at among European national TB programs, the relatively higher burden countries were more likely to have specific policies for adolescents, and were also more likely to expect adolescents to have an increased risk of progression from TB infection to TB disease. Now, you will notice that even though they were higher burden countries, that actually adolescent-specific carve-outs in the national policies occurred less than half of the time. When you look at low burden countries, maybe because of the perceived need for a specific carve-out for adolescents was less, really a very small minority of those countries actually had specific adolescent policies. Why is this important? It's estimated that there are about 1.8 million cases of TB in adolescents a year across the globe. So this is not like this is a small population of people that we're talking about. And where you expect to see the cases, I mean, it's really based on two things, right? It's based on where you expect to see cases of TB generally, and that's the map that's on the right-hand side of the slide. And then what are the population, excuse me one second.
Would you mind just going just a little closer,
Yep.
maybe a little louder, because just some.
It's still, okay.
Yeah.
Guys, I'm so sorry, I'm a soft talker. Please message Lauren if this is not any better with us. But we also know that the other thing that is important in terms of thinking about the demographics of where adolescents get TB is really based on population structure in individual countries. So we know that in North America, for example, adolescents comprise about 4% of the population structure. That can be as high as almost 30% in some Southeast Asian and South Asian countries. So why do we care about mental health and TB? And I'm not here as somebody who is an expert in mental health, because that would be a farce for me to claim that. But I'm here in terms of somebody who really cares about how do we take care of these kids. And from a humanistic standpoint, we know that depression is really common. We also know that depression is uncommonly addressed. Might be uncommonly addressed because the kids don't want to allude to depressive symptoms, because acknowledging mental health disorders is very culturally driven. But we also know that for many of our kids, we are the only avenue they have to healthcare. They don't have a medical home, they don't have a pediatrician or a family practitioner. And a lot of times they've had a lot of unmet general needs that are outside the realm of just purely TB. Aside from the humanistic, there's also the practical perspective. We know that adherence improves if you address mental health conditions. It doesn't matter what that underlying problem is. And we know that clinical outcomes are almost uniformly better if patients are not depressed, right? So we have two sort of compelling buckets of reasons why we should care about mental health in these kids. Data from adults actually shows that individuals who have what's considered to be a growth trajectory in terms of increasing depressive symptoms during the first half of their TB therapy were far more likely to be lost to follow-up in the second half of their TB treatment. And this was actually remained the case even after you controlled for sociodemographic factors, including factors associated with structural violence, and after in the adult population, you controlled for ethanol use. So what are the things that our adolescents tell us about? They talk a lot about the feelings of stigma and guilt after they're diagnosed with TB. So why is there stigma? So what happens when you give a patient a diagnosis and they don't know anything about the diagnosis? Well, if you're anything like my patients, the first thing they do is they pull out their phone and they Google it. And then you get headlines like the ones that are shown on this slide. And so not surprisingly, their friends do exactly the same thing, right? And these are quotes from a paper by by Sylvia's research group that actually really talk about the role of stigma after a diagnosis of pulmonary TB. I like these quotes because I think nothing speaks so powerfully than letting a patient speak for themselves. But it's also, I think, really important because if you know where these kids lived, they lived all over the globe. So stigma is not a problem that is isolated to one particular geographic area. It is, very much, unfortunately, very egalitarianly distributed across the globe. where these patients felt like they were being ostracized by their communities. Some of this sense of being ostracized probably stemmed from the fact that in addition to having TB, there's very much this perception that TB is a disease of poverty, which in many areas it is. And so they also felt ostracized socioeconomically because of their family status. So one of the things that Sylvia and her colleagues did in Peru was they actually validated a TB stigma scale for adolescents. So it was for adolescents who were over 15 years of age, and it really focused on a couple major themes. It talked about fear of how do you disclose your status to families, fear of people finding out that you have tuberculosis, thinking that if you have TB, is that somebody who also carries a diagnosis of HIV infection? It felt guilt about why they developed the disease. Was it because they had poor nutrition? Was it because they had substance abuse? I had one of my teenagers who said, I thought I developed TB because I stopped going to church. And then feelings of isolation. They felt alone because they had TB. They felt very emotionally injured by the way that other people reacted. And why is the stigma scale important? It's because it's associated with a lot of other health outcomes. So we know that having the stigma scale being high is associated with increased risk of depression and suicidality. This is for kids across the age group. This isn't just in patients over 15 years of age. But one of the things that they found was for older teens, in addition to being associated with these outcomes, it was associated with feeling like you had less social support. And that was definitely associated with the increased stigma. It was associated with feeling of guilt, risk that was posed unwittingly to the patient, to their family and friends, feelings of guilt because they didn't understand the causation of how they got TB. So in the absence of knowing about the pathophysiology of TB, what do patients go to? They go to what they understand for other things, right? They go to, and that's hence the association with thinking about, is this related to poor nutrition on their part? Or is this associated with things that might have been under their control that they did incorrectly? There's feelings of guilt because in many countries, frankly, adolescents contribute sometimes, and not in an insignificant fashion, to the income that is being brought into the home. And when we often think about this in our adult patients, or not my adult patients, because I'm a pediatrician, I have no desire to take care of adults, but in your adult patients, we think about it in terms of you tell somebody to stay home from work because they're in respiratory isolation, and there's an economic hit that family's going to suffer. Sometimes we don't realize that economic hit that a family can incur is also present if it's an adolescent who's contagious. And in addition to, it's kind of a double whammy for these kids, because in addition to not being able to work, they're also increasing the cost of the families. The drugs might be free, but how do you get to the clinics? How do you pay for x-rays? A lot of times that's out of pocket for families. And then when you think about respiratory isolation, it's clearly a public health need, but it's also important for us to recognize, how do you try to balance this? And I'll come back to this at the end of the talk, of how do you, balance the need for respiratory isolation for the protection of others by not sending an adolescent spiraling into depressive symptoms because they've had social isolation, they've had disruption of school, they've had disruption of their relationships with their boyfriend or girlfriend, for example. And these are, again, some quotes. These are from Peru, but I think you can probably drop these quotes into any country, and those would continue to resonate. He's sad because he doesn't like to miss school. I will say that this probably doesn't resonate with many of my patients who think that missing school would be phenomenal, okay? But they talk about your academic progress stopping. How do you pivot after you had one career goal, and that seems like that's not available to you based on the fact that you've missed school? How do you maintain relationships with friends when you're not seeing them in person? And so you can see there's sort of this cycle of what happens for these kids. So they're on home isolation. In many countries, the kids are isolated for far longer than they actually need to be for medical indications. And sometimes, until their regimen has been trimmed down to just a couple of medications, in many countries, those kids are kept inpatient for the first 2 months of treatment. So this leads to missing school, being separated from individuals that they love, stopping playing sports, which for many of our patients is the main reason they go to school, is to have continued ability to play sports. You take that motivation away. Sometimes you take away that motivation for that kid to remain in school. This leads to academic setbacks. The academic setbacks then spiral into feelings of depression, feeling like they're not up, to par with their peers in terms of what they can do in the classroom setting. This leads to decreased earning potential. right? I mean, what kind of jobs can you get in the US, for example, without even a high school degree? And the likelihood of somebody dropping out, especially if they were sort of right on the bubble of academic performance, is going to be higher for some of these patients. And all this leads to a lot of threats to their future well-being. And I think sometimes I know I spend a lot of time focusing on how do I get the patient, over the hump in terms of their TB medication. But maybe sometimes it's worth thinking longitudinally about how what you're doing now can impact that kid in 10 or 20 years. These are, again, some quotes from different areas about educational disruptions. A child in Cape Town reported they could not read Afrikaans anymore because it wasn't the language they spoke at home. It was only a language they took at school. So again, you have this cascade. The kids are out of class. They might have problems with treatment adverse events. This leads to some learning difficulties, regression of skills. Then they bail on school, or they change their career trajectory, and they no longer shoot for finishing high school and going to vocational school, or finishing high school and going to college. And then again, this sort of spirals back, and this leads to, in some cases, frankly, multi-generational poverty. This is a different paper that looked at social determinants of who adheres to therapy for TB infection and disease among really kids from birth until they were young adults. And many of the factors are, frankly, factors that are very difficult to have within our control. A lot of it relates to structural violence, including poverty and violence in their communities, inequities and gender norms. But you can look for the factors that you start to see in adolescence, which are in the red box at the bottom of the screen. You can see a lot of these are actually potentially modifiable by our systems. This includes, how do you work around scheduling conflicts for school or work for some of these patients? How do we teach them more about TB so they feel like they have some control over the situation and they can explain the disease that they have? Again, this is another study from Peru. It actually looked, and it was interesting. It asked adolescents and their families, and also asked healthcare providers, what are the barriers that you see in different aspects of the healthcare system? And as you can see, it's just very interesting for healthcare providers, who I think were often very uber critical of our systems. There were not a lot of healthcare providers who identified potential barriers for their adolescents to receipt of care. The adolescents and their families, however, identified a litany of potential concerns that made it really quite challenging to receive care. And this included the requirement for daily in-person DOT. So remember, for families that might have been relatively recently arrived to this country, that the idea of in-home DOT, the idea of virtual DOT, is very much something that we see in the States, and we have the luxury of being able to do in the States, but should not be something that you think that a family would understand would be an option, right? So if your family is from Peru and they know that every day Johnny's got to go down and take 3 buses to get to the TB clinic to get his meds, and that makes him miss school, you can imagine why there might be reluctance to seek care after they're able to get out of Peru and make it to the US. So when I talk, what are potential solutions that are within our realm to do? So expansion of VDOT, right? So when I think about what is the only good thing to come out of the pandemic, aside from me adopting a couple dogs, I think about video DOT being expanded, right? There were a lot of places that had minimal VDOT available pre-pandemic. And as everyone in public health got pulled in 14 different directions with the pandemic, we really had no choice but to increase VDOT in the community. And so, integrating this, there's no adolescent who wants to get up at 5:30 in the morning to get DOT before wandering off to school. So it gives adolescents a sense of autonomy. They can select the time in the day that works best for them, not a time in the day that's a Venn diagram of overlap where it works for them and it works for a public health worker. Texting them reminders. Our adolescents receive hundreds of texts a day. If you think they're going to be bothered by receiving one more text, I would say that that's very much a misconception. And again, it's giving them information in a fashion that they're already used to either communicating or receiving information. So it dovetails well with their existing paradigm of how you communicate with people. What about socioeconomic factors? So again, these were more identified by adolescents and their families than they were by healthcare workers. And there were a number of these that were identified. I'm sorry, I'm trying to move the floating window out of the way a little bit. So what are some potential solutions to this? One solution is food baskets. These have been utilized well in many countries where, If you expect somebody to actually stay home from work and you don't want their family to starve because of that, you have to make up that shortfall somehow. I would say that we probably grossly underestimate food insecurity in the United States. I know that when I ask about food insecurity, the answer is almost always yes, which is a reminder to me that I need to ask about it more. How do we get assistance with transportation to clinic? There's maybe one car and it's owned or it's driven by the main breadwinner in the family who has a job where they don't get sick leave if they miss a day of work. Of course, that kid's going to miss clinic appointments because that family's got to pay the rent. So, is this something that the adolescent can be transported by the health department? Are there flexibility to see the adolescents without their parents being physically present? Can we optimize virtual visits so you have engagement of the family, especially, obviously not for the initial visits because you have to do your chest x-ray and your exam, but for those in-between visits where you're not doing imaging, if everything is going well, how lovely would it be for the families to be able to do those visits from home? Patient-related. So there's a lot of embarrassment about having to go to a TB clinic. They felt, many adolescents feel invulnerable. They don't just feel invulnerable to TB, they feel invulnerable to like everything, right? So how do you potentially address this? Well, you get around the stigma potentially through VDOT, right? By not having a car with a health department logo pulling up into the driveway each day, that might make therapy far more palatable to families. Again, I focus on addressing food insecurity because as a country, we do a very bad job of this, and actually included a link to a site that helps you with finding your local food bank for families. I think this is incredibly helpful. It's also a demonstration to families that we care about the family. We don't just care about treating the kid's TB. And then in places where you can, what a great idea if you could have family-based therapy, where you have both internists and you have pediatricians so that the kids can be seen, the adults can be seen, and that all happens sort of on one clinic day. So the family is not having sort of fragmented care. They also relate factors related to therapy, challenges in remaining motivated throughout a long treatment course. This is not adolescent specific, right? We do a bad job with chronic disease in this country. Look at our outcomes with type 2 diabetes. They're abysmal. And in part, it's because, dealing with a chronic disease is challenging for adults. There's no way we can think that it wouldn't be potentially even more challenging for our adolescent patients. The pill burden is high. Not all of our teenagers can swallow pills. And then once people start feeling better, they stop taking their meds or they want to stop taking their meds, right? Who finishes the 10th day of amoxicillin for strep throat? Pretty much no one does, right? So what are some potential solutions? So I try to communicate directly with the teen versus the parent when I'm seeing the parents in clinic. And I tell the parents this so they don't think that I'm avoiding eye contact with them. But I say, look, at some point, your kid's going to be in the driver's seat for their medical decision making. That should not be like an on-off switch that occurs only when they turn 18. They have to have graduated responsibility, and that's why I'm talking directly to your kid, not to you. Having educational materials that target adolescents. A flip book on TB might work really well for a kid in elementary school. You give that same educational material to a teenager, and they feel insulted, they're going to be disengaged. You need to address their feelings of invulnerability. This is pretty hardwired into the American teenager core, and unless you address this, then some of the decisions that they make might not make sense to us. Having fixed dose combination pills, they exist. We use them, I think, very infrequently with our teenagers. And then, even if it's exactly the same drugs, by having fewer pills, the perception is less onerous on the patient. For those kids who can't swallow pills, we need more child-friendly formulations. Countries have developed these easy dissolving tablets where you drop them into a very small cup of water. They dissolve, they taste like mango. They're amazing. How do you incorporate medicines into the kid's daily routine? I always tell my patients, you should take your meds before school if they're on VDOT, because extracurricular activities might mean that the kid is not necessarily home from school at the same time each day. And usually families have a very fixed routine in the morning. They get the kid up, they get the kid breakfast, the kid is dressed, the kid is out the door into the car and onto the school bus. So by integrating it into an existing fixed routine during the mornings, that might increase your chance of success. And the last one is we use a treasure chest for our little kids, or they get to go pick a book off the bookcase of clinic or something like that. How do you do that for kids? Maybe it's cell phone minutes. So this was a study that I read about in the incredibly non-peer-reviewed in-flight magazine for South African Airways when I was there several years ago, where they had a urine dipstick, and the kids would urinate onto the dipstick, and if they had high enough concentrations of TB medication metabolites in there, a code would appear, and they could redeem that code for cell phone minutes. I unfortunately have not been able to find the publication that I hope resulted from this, but it's things like this, thinking outside the box for how to engage with our teens. So when you think about depression and suicidality, we know that this is seen in up to 65% of adults with TB in some studies. I knew that it was higher than the general population. I don't think I realized it was that high before I did this lit review. We know that COVID has not helped mental health. That there's a huge body of data talking about the proportion of emergency department visits for mental health conditions since the onset of the pandemic, when the numbers really skyrocketed. And we know that there are factors that are associated with increased depressive symptoms in patients who have TB. And this is, again, a study from Peru using a validated depression scoring scale. And it, again, not surprisingly, found that the incidence of depressive symptoms was higher in girls than it was in boys in this age group. That it was interestingly higher in the 13 to 16-year-olds than in some of the older teens, maybe because the older teens had maybe a bit more sense of control over their outcomes. It was associated with what are called adverse childhood events. And these are things that are really not under the kid's control. Parents being divorced or being split, violence in the home, violence in your community, poor access to schools that might not be of as high a quality as we would hope for our own children. And then hunger. Again, this should come as a surprise to none of us. So, what are things that we can do? There's a suicide screening tool that's called the ASQ. It's for Ask Suicide Questions. It says, in the last few weeks, have you wished you were dead? Or that you thought your family would be better off if you were dead, which is sort of a terrifying question that a kid might answer yes to. Have you had thoughts about killing yourself, or have you ever tried to kill yourself? And answering yes to any of these very much increases the risk of future suicide attempts or suicide completion. And remember that unlike Peru, in the US, kids have much greater access to lethal means. And so that's why the rate of suicide completion is actually higher in the US than it is in countries where gun access is more restricted. When we think about, it's not just diagnosing a child with mental health concerns, but it's also the importance of, if a kid is already on treatment for depression or for other findings, then recognizing the impact that our drugs might have on those medications. So the interaction column in the right is in black for rifampin, and the interactions with INH are in red. We all know rifampin interacts with everything under the sun, so it's not surprising that it would decrease the levels of some of your mood stabilizers and your antipsychotics, that it would decrease the levels of your antidepressants and benzodiazepines. And in contrast, INH will actually result in increased levels of some of these things. So you don't want to send somebody into a serotonin surge because they're on INH and there was not a communication with their psychiatrist to decrease the levels of their antidepressive medications. I put this in here because sometimes I think we think about stigma and we think about depressive symptoms, and we think about it only in the patients who have TB disease. But it's important to realize that a lot of these same emotional feelings that an adolescent has after they're diagnosed with latent TB infection might mirror some of the same emotional response that they have when they're diagnosed with TB disease. So this was a study that was published in the Union Journal last year that actually looked at the frequency of depressive symptoms in household contacts of cases, stratified based on whether or not that household contact actually had TB infection or not. And what you can see is that the household contacts who had LTBI at baseline had almost twice the odds of having depressive symptoms as those who did not have a positive test at baseline. So important to consider this. So how do we address this in the population with TB infection? I spent a lot of time at the first visit talking about, hey, I know that your parent, your insert index case, had to stay out of work or out of school after their diagnosis. That is not the case for you. We do not talk to the school about your diagnosis. It is not the school's business that you need to take therapy for TB infection. We can do video observed, video DOT for certain families. I do tell our adolescents that I try to avoid giving medication at the school. Sometimes it's inevitable because the child might have a very fragmented time where they sleep in different places at different times and things like that. And if VDOT doesn't work, then sometimes school might be your only option. But I really try to keep the school out of this because that might be a safe space for the kid where they can just focus on something that's not what's going on at home. And by putting the meds in the schools, you take away that safe space for the teenager. I give them what I call a chest clearance letter. I tell them, hey, this is not your school excuse. I'm going to give you a separate school excuse every time you come to clinic. But I'm giving you this letter in case you need to go see a dentist, in case you need something else, to occur in your life to show that you are not contagious. And I talk to them upfront about social media considerations. I admit to being blown away by the amount of information that my teenagers share on social media. I had one of my patients who wrote her essay for her freshman composition class on the fact that she had latent TB, and it led to sort of this firestorm of reactions where the teacher didn't know what latent TB was, and they thought the kid was contagious, and the kid ended up having suicidal thoughts afterwards. So I talked to them about what is their business versus the business of the world. I discuss substance use and abuse as well. This is something that I think we do a disservice to our patients by not acting like they're, all very naive teenagers who have never thought about or experimented with substances. And I'll end with the rifamycin in a moment. So substance use and abuse, we know that about half of kids will have tried alcohol. About 40% of them will have used an illicit drug. Vaping is often considered by teenagers to not actually be substance usage. So I specifically ask about vaping in addition to asking about smoking, drinking, and using other drugs. And we know that marijuana is the most common illicit drug that's used by teenagers. And remember, even in states where it's legalized, the legalization age is 21. So if they're still being seen by me and they're using marijuana, it's definitely not legal. And then about 80% of high school seniors say that if they wanted to get their hands on marijuana, it would be easy. So there are substance abuse screening questions as well. This is by the National Institute of Alcohol Abuse and Alcoholism that actually asked a single screening question. And it said, how many times a year have you had, if you're a woman, 4 or more drinks a day, if you're a guy, 5 or more drinks a day? The reason for the difference between the sexes is because alcohol is metabolized differently by the sexes. And it's because binge alcohol use is definitely associated with use of other substances. When should you start screening? The answer is about 4% of 12 to 13-year-olds. And it's thought to have declined a little bit, but these are slightly older data for which I apologize. I couldn't find better recent data. But in 2002, 4% of 12 to 13-year-olds had used alcohol within the past month, and that went up to about half of teenagers by the time they were high school seniors. Binge drinking, and that's really the source of that question by the NIAAA, is found in about 10% of within the last month in some series. So last thing I always talk to my adolescent patients about, and I apologize if there's anybody on this call who is a New York Yankees fan. Astros have spring day and we open next Thursday against the Yankees at home. So I always tell my teenage patients that being on rifampin is a bigger deal for a teenage boy than it is for a teenage girl. And the reason I say that is, when we go to an Astros game, for example, and you have to go to the bathroom, women have the common sense to go into a stall and close the door and do our business. The guys are urinating in front of other people. So the likelihood that somebody's going to notice the rifampin orange urine is far greater issue for a guy than it is for a woman. And this is at a Houston restaurant where the Yankees were playing in Houston against the Astros for, I think it was the American League Divisional Series. And somebody nicely put a Yankees logo at the base of the urinal. So what are some take-home messages, ending on a slightly lighter note? So we can help these kids. We can obtain frequent sputum smears so these kids have less interruption of their schooling. We can use validated tools if we have concerns about patients. And one of the things is, are these tools that maybe should be integrated at the time of intake? Again, because many of these kids don't have another medical home. So their preliminary encounter with contact investigation or their encounters with me in clinic might be the one and only chance we have to potentially identify a problem before it gets completely off the rails. And then lastly, if we have concerns about a child having depressive symptoms or suicidal symptoms, I would say please don't leave TB medications in the home. This might be a time where using VDOT might not be a good idea. If kids are going to sit there and they're going to overdose on something, they're going to reach for something that is already in their home. And that's why so many teenagers try to overdose on acetaminophen or Tylenol. What we don't want is that the kids have a large supply of INH in their home, and that's what's accessible. That's what they reach for. They swallow the entire month's supply of INH in one suicidal attempt, and they come in with status epilepticus. Because I will tell you, it might take a while before we as emergency medicine physicians get to the point in the algorithm where we've given drug after drug after drug, the kid is still seizing. And if nobody provides that history of there being INH in the home, then we're not going to give the antidote to it. With that, I want to stop and still have a couple minutes for some questions. Thank you guys so much.
Thank you so much, Dr. Cruz, for all the information that you had to share regarding the emotional impact on our adolescents and our youth. I'm monitoring the chat right now, and aside from so many people saying what a great presentation it was, I'm not seeing any questions just yet, but I do sometimes get like some questions as like a photo finish, so we'll give them like a little bit of time to think about it. But if I don't see anything soon, then we'll go ahead and we'll transition to our next talk. Oh, like for instance, Anna Kirby Lima just asked a question in the chat. She said, just Googled, is vitamin B6 the antidote to INH?
It is, and it's the antidote. It's usually given intravenously because if they're seizing, they're obviously not going to be able to swallow it. And it's usually, the antidote is given on a gram by gram basis. So because we rarely know exactly how much a kid took, usually we'll give them several grams of B6. Remember, if they have enough in their system, they just pee it out, not a big deal. It's the joy of a water-soluble vitamin. Usually it's such a big amount that we give them that it kind of depletes our hospital stores. Then we need to like borrow meds from like the next hospital over for the rare cases we get an INH overdose. From the standpoint of before starting anti-psychotic or depression medicines, do you think we get a clearance first? What I would say, that should be a good communication between the TB clinician and whoever is managing their psychiatric drugs. Sometimes the kids go to those visits maybe not with family present and might not convey the meds that they're on. So usually I say, is it okay if I talk to your psychiatrist? And then I call them and I say, hey, I'm going to be starting on this medicine. Sometimes we will select for TB infection, we will select a different regimen that doesn't interact with their existing psychotropic meds. So that's one of the few times I still use INH as monotherapy for the treatment of TB infection, is there's a kid who's on 3 psych meds and they're all going to be altered by administering rifampin. And if I give them INH, they're not going to have a problem with their psych meds. So I'll talk to the parents, it's shared decision making, and talk to the teen obviously, and say, look, we could do a shorter course therapy, but for the next 3 months, your meds are probably going to be wonky and your levels are not going to be great. Or we can do a longer course of therapy and, and not have to worry about drug interactions. And I will say that almost always the teenagers say, I'm at a pretty good place in terms of my depression or my bipolar. I'd rather take it for a longer period of time rather than risk drug interactions. And guys, I do apologize. I've been like almost screaming at the microphone, so I'm not quite sure why Barbara, who has a very soft voice, was able to like sit at the same computer without problems. And I'm like screaming at it, and you guys are hearing me speak softly, so I do apologize.
No worries. It seems like we've covered all the questions so far, but Dr. Cruz, please feel free to hang on for just a little bit longer, monitor the chat in case we have any latecomers. Otherwise, we're going to go ahead and say thank you once again for your time and for sharing your knowledge and expertise with us. It was so helpful. And so with that, I'm going to go ahead and ask for you to mute so that way I'm not getting the weird feedback loop. Thank you. And then I'm going to kick it back right to a familiar face with Dr. Armitage. This one she gets all to herself. She doesn't have to share with nobody. So Dr. Armitage, if you can share your screen.
Yes, I can, but I was so all into what Dr. Cruz was saying that I was not ready. So hang on one second. I'm gonna open it up right now. Y'all seeing me?
Yep, we sure can.
All right. let's get going on. So now this is the last, bringing it home. So this was something I admit I said is from the news desk. This happens at Barbara Seaworth's desk. So I went down to her desk and I was telling her, I gave a grand rounds in Houston, actually at the med school in Houston. And I had something that I was telling her that, and she's like, you need to talk about that. So when Barbara Seaworth says you need to talk about that, you talk about that. So I want to talk about reassessing LTBI, who we missed and where are they now. First, some San Antonio numbers. We're getting killed. And I don't know if everybody else is having the same type of experience we are, but we have 24 confirmed active TB cases for 2024. And from 2019 to 2022, we had 2019, we had 14, and then 2020 and 2021, we had 15, and then 2022, it went back down to 14. But this year, we have that's for us a whole 1/3 increase. My patients are ranging from 10 months to 88 years old, so I'm hitting the whole spectrum. But, before I get into what I want to talk about, I wanted to bring, and I want to just give a huge shout out to Annette Costa for setting me up for this talk. 15 of our 22, or about 68%, were foreign born. Another 2 lived outside the U.S. They were born in the U.S. but lived outside of the U.S. 9 patients arrived in the U.S. less than 5 years ago, but 6 patients, almost fully a third of them arrived between 14 and 83 years ago. So when you look at that, I mean, this is the standard curve that we see every year, and they haven't come out with the numbers for 2023 yet, but every year we're looking at this blue bar just not change, okay? And so, you keep thinking, well, okay, these are, individuals that are non-US born individuals, and, and that this is people who are coming into the US, and we just, we can't, we're having a hard time keeping up with that, but not always the case. So I want to start off with just a, specific, patient. Let's just put this into perspective. So you have a 50-year-old man from Honduras. He immigrated to the US 20 years ago, and he recently changed jobs, and they required an IGRA for employment where he'd never been tested before. This time he tests positive. And when you're talking to him, he says, yeah, he tested positive with a TST in the past, and he attributed that to being BCG vaccinated. And that's what, people with BCG vaccinated are told. They're going to be, positive for life. And so he's currently doesn't have any symptoms, and he has a negative chest x-ray. So what is your messaging to this man regarding LTBI treatment? So I want to look here. This came out of the CDC numbers last year. It was one of the slides in their slide deck. If you look at just, so, initially we were like, okay, anybody who's been here, is high risk for TB was considered anyone who's been here, 5 years or less, who immigrated to the US, that was the high risk group. And then that group went up to 10 years or less. But if we just stay at people, if you're, 10 years or less, and I guess your risk goes down, we're still missing 51% of people. 51% of people who immigrated to the US greater, over 10 years ago are represented in our active cases, okay? Then if we look at 20 years, and this is a little bit older because they only did this one time and I snatched up this slide. But if we looked at people who have been in the US 20 years or longer, that's still 1/3 of the cases that are represented in our active cases in a year. So these are, and I want to point out that these are people who have melted in our pot. But after 20 years of being in the US, you have had your children, you're seeing your grandchildren, you have worked your job, you have retired, that you get to that point. But these are our citizens who just brought the risk of TB that they had from their home country with them. And just as Annette was saying, half of the cases are individuals that are 45 to 64 years of age. So, or I'm sorry, 45 to over 65 years of age. So, half of our cases are in older groups. Most people who, when they're immigrating as young people. They are coming here, in their younger age. And so when we're looking at our non-US born population, this is about half of them, and have been here. If they're at 45, they've probably come here in their 20s. maybe 30s. So they've been here 15, 20 years already, and already, again, melted into our pot. So now, how to treat. So you discuss the risk with the patient. You let him know that his risk is not, really going to decline. He still has, 1/3 of our cases look like him. So, you discuss risk and he agrees to treatment. So how do you treat this person? So here are our treatment recommendations. So, I'm not going to go through the whole, run of them, but again, 3-HP, being at the top of the heap, 12 doses that you have to give a patient instead of taking over hijacking their life. At 50 years old, he might not want to take that many pills. Maybe he takes some other medications. Maybe he wants a daily med. Rifampin 4 months, again, is our next shortest regimen. INH plus rifampin for 3 months. And then isoniazid for 6 to 9 months, being way down low on the totem pole. So 4 months of rifampin or 9 months versus 9 months of isoniazid for LTBI. This was, finally we have an actual paper that comes out and tells us what this looks like. And so the completion rate, the biggest part, of the paper, the completion rate for rifampin was almost 80% versus isoniazid being 63%. And this was comparing, again, 4 months of rifampin versus 9 months of isoniazid. And the biggest difference being in the rate of completion for folks, and where to, and I want to point out 63% completion in a study. So, in a study, they're checking in with the person, they're looking for toxicity, they're doing regular visits, and this is about as good as you can get for completion. It's kind of sad. Clinically significant hepatotoxic events. With isoniazid low at 1.7%, but with rifampin 0.3%. 0.3% likelihood that you're going to have clinically significant, meaning you have to stop the meds, hepatotoxic events. So basically the take home of the study, 4 months of rifampin was not inferior to 9 months of isoniazid for preventing development of active TB, but there were significantly higher completion rates and there was greater safety than isoniazid. Rifampin toxicity, cutaneous reactions, seems like, you get a lot of patients with hives. Mostly you just remember the ones who get hives. It's about 6%, which is, not small, but not huge. Orange discoloration of body fluids, gastrointestinal symptoms. You have some nausea, anorexia, abdominal pain. Flu-like symptoms, less than 1% of patients on intermittent therapy. So again, you notice that with patients who take, we used to have intermittent dosing of rifampin, but we've really tried to get to daily dosing of all of the medications with patients who have active disease. But that intermittent dosing was really noted in patients with active disease and less so in patients who took medications daily. Back to the GI symptoms, that usually is early on. You take the medications with some food and most of that will resolve. Severe immunologic reactions, what we're always worried about: thrombocytopenia, hemolytic anemia, acute renal failure, thrombotic, well, TTP, thrombocytopenic purpura, less than 1%, less than 0.1%, less than 0.1% in patients. And then severe hepatitis is nearly zero in monotherapy. So in the study that I showed you is 0.3%. Is to the point that you stop, but to the point that you actually cause harm is so low, it's almost 0% in monotherapy. It says it may appear cholestatic. So if you have a patient that has a high bili, but the transaminases, the ALT and the AST look normal, and it's only an elevation in the bili, that's usually rifampin. Okay, here's a problem, is that rifampin interacts with everything, so the oral contraceptive pills, for the ladies, biggest thing are patients who are on immune suppressive meds for transplants, digoxin, steroids, itraconazole, the name goes on. But when you start getting down here in our older patients, verapamil, and amiodarone. So you may have patients who are on medications for heart medicines, the diabetes medicines, thyroid medicines. So those medicines can be impacted by the rifampin signaling for the person's liver to ramp up and metabolize those medications a lot more aggressively. So in those cases, just consider rifabutin and see if you can make the exchange. So let's see, here we go. So isoniazid, in the event that there are some patients, and as Dr. Cruz mentioned, there are some patients that have several medications, and you look at that list of medications, you say, well, I really don't want to impact their seizure meds. So there's only 2 patients that I'm really not very aggressive with the rifamycin for, and those are patients with histories of seizures and patients with histories of arrhythmias. Because all I can think of, I send somebody into, status epilepticus, not only would Dr. Cruz think less of me, but I will think less of myself. So I'm really trying not to impact that person's seizure meds, but also, any arrhythmias. These are kind of life-threatening events. So I try to avoid that. And if it really looks like the rifamycin is not going to be something that's going to work, any of them, then looking at isoniazid therapy, this was the treatment, the standard of treatment, forever until we got better, shorter regimens. And 9 months has been the standard, was the standard until we have recent, better options. So the new guidelines do suggest that instead of 9 months of treatments, 6 months would be adequate, which is better. That trims off 3 months of somebody's life. The regimen is very effective. It is the preferred regimen for patients who are on antiretrovirals or patients who have drug-drug interactions that don't allow rifamycin. So, it's the option when drug-drug I combined the 2 in the points before, but keep in mind less than 60% completion on the average. So it's primarily due to the long duration of treatment. So if you're going to put someone on isoniazid, not only do you want to watch over them, but you also want to help them try to beat the fatigue that comes with taking it. Hepatotoxicity, you get asymptomatic elevations of the ALT and AST in 20% of patients. It's just asymptomatic. 1 in 5 patients is going to see an elevation in the transaminases. Usually it will come back down, but you do see an increase. Clinical hepatitis, only in about 0.6 patients. But fulminant hepatitis, this is the one drug in our arsenal that we have seen this, except the old rifampin and PZA that got taken off. That actually was the highest rate, caused the highest rates of fulminant hepatitis. In patients on isoniazid, this is about 4 per 100,000. You will hear old docs say, well, your risk of progressing to active disease is smaller than your risk of having hepatotoxicity, and they use that as a reason not to treat. Well, that's not the case in the new rifamycin-based regimens. All of those regimens are very low, but we still have, sometimes when we have to use isoniazid, keep in mind that you still have some risk with using it. So severe liver disease, there was actually a retrospective look that was published in the MMWR. There were 10 patients where the CDC went on site to investigate what happened. All the patients had the correct indications for treatment for LTBI. All of them were prescribed isoniazid within the recommended treatment range, and all of them took the medications as prescribed. So there was nothing wonky going on there. The prescribers followed the guidelines for monthly monitoring. But in most of the patients, the symptoms occurred over the whole span of 9 months, all the way from 1 month into treatment to 7 months into treatment. But 2 of the patients had discontinued the medication within 3 days of developing symptoms, but 8 of them stopped at least 1 week after starting the onset of symptoms. So what came out of this was the most important thing medical providers have to emphasize to patients. INH treatment should be stopped immediately upon the onset of the earliest symptoms, and they should contact the clinic. Even before clinical evaluation has been conducted, and the initial symptoms may be subtle and might not include jaundice, they just may have any excess fatigue, nausea, vomiting, abdominal pain, or jaundice. If you put the patients on isoniazid, it can be done safely, but you just want to let them know. If you notice that anything seems not right, like anything in your body just doesn't feel right, stop the meds right away and give me a call. And that way, the safest thing is to bring the patient in to have them evaluated. So the biggest side effect concerns, hepatotoxicity, migraine headaches, if you have a patient with a history of migraines that can trigger, gastrointestinal issues like nausea, diarrhea, constipation can upset the GI tract. Again, having some food with the medication does help. And usually if it starts early, it'll fade as things progress. Rash, again, a little bit less than rifampin, but still rash. And then peripheral neuropathy, which can be mitigated by giving the patient 50 milligrams of pyridoxine. So treatment for LTBI infection, just keep in mind that this was oops, sorry, on the wrong way. This was a study that was published in the Annals of Internal Medicine, and it ranked the available medications for treatment of LTBI based on their hepatotoxicity, and the number one and safest was rifampin, daily dosing. I would also add in that would include rifabutin, daily dosing as well. Number two was the 3-HP, and number three was INH and rifampin dosed daily for either 3 or 4 months, depending on which study was being reviewed. But lowest, like the worst, again, as I mentioned before, this regimen was taken off because it was, very, very ranked very high in causing liver damage, and that was the daily rifampin plus PZA. So that got the lowest rating. But then when you look at the ratings prior to that, isoniazid for 6 months rated 5, isoniazid for 9 months rated 6, and then isoniazid for 12 to 17 months ranked second to last. So the rifamycin containing regimens, if you can use them, are going to be the safest. And I want you to remember that the U.S. Preventative Services Task Force recommended for LTBI that screening for LTBI should be done in populations that are at increased risk. So these populations that we've missed, this was largely, when they looked at this, individuals who were born outside of the U.S., so non-U.S. born individuals. Also, your individuals in congregate setting, high-risk congregate settings, like jails and prisons and places such as, but also places, other places in your communities that are found to be of high risk. But I think, when I say who we've missed, a lot of individuals came over, and I describe them as folks that came over in the 90s, especially 80s and 90s, came here to the U.S. to find a better, better opportunities, and melted into our pot. And these people went in and they tested positive by TST because there were no IGRAs in the 80s and 90s. They tested by TST. The assumption was that they were positive because they were young and BCG vaccinated, or they were given isoniazid for 9 months. You get the first bottle, they tell you to take the medication every day. Now, if you can imagine, you just came here from Iran, from Pakistan, from Mexico, from Latin America somewhere, and English is not your first language. And they're explaining to you in English about taking this medication, you don't feel sick. So you go home, you take that first bottle of medication, and then you're done, because that's what they told you to do. Check and done. And if they gave you a prescription for 8 more refills after you take the first one, you feel great, no need, right? So we have a whole generation of folks that we have just kind of missed. And I feel like when we're looking at those bars that are not going down, and we're knowing that half of the people that are represented in that bar are part of our U.S. citizens who were not being taken care of, and also a third of them have been here over 20 years, then I think we are failing. So I'm going to leave that with you, that I know there's somewhere in your community, somewhere in your FQHCs and in your groups, such as that you need to be talking to about finding these people and getting them into care. And that is my last talk for the day. I'm going to stop sharing and hand it back over to Lauren.
Thank you, Dr. Armitage. So I do see that we have a couple of questions that are in the chat. So I'm going to take a moment to make sure that I'm getting them in the correct order real fast. Let's see. And Record asks, what's the rifabutin dose? And this might have been towards the beginning of your presentation.
Rifabutin dose is 300 milligrams daily. So like the rifampin dose is 600, just remember half that. The rifampin capsules come in 300 and rifabutin comes in 150, 2 capsules. It's 300 milligrams.
Next question comes from Anna Kirby Lima. She asks, do we have same safety and completion rates for rifabutin in place of rifampin?
So that's a big thing. We do not. And actually in the HHS guidelines for HIV, they do not recommend substituting rifabutin for rifampin because there's no data in HIV patients at all. So where we get that from is the 2003 guidelines stated explicitly, and in the event that there are drug interactions and you cannot use rifampin, that rifabutin can be substituted for that. That is stated a little more softly in the new guidelines that we have from the CDC, IDSA, and ATS. But in general, the drugs can be considered interchangeable. Is there an actual study that we can quote? No. It's mostly just looking at substitution and looking at kind of the patients that we've been able to see. But is there a rate? I would say that rifabutin is a safer drug. That would be the other thing. It tends to be gentler on the liver and it has its own side effect profile that's a little different from rifampin, but equally as effective. Oh, and is the treatment for rifabutin 4 months? Yes. Basically, you're just exchanging. And if you start a patient on rifampin and you have to switch them to rifabutin, you can count all of those rifampin doses. So you want to do 4 months of treatment in a 6 calendar months. If not, you have to start over. It's kind of like that old 6 months of isoniazid in 9 months, or you have to start again, or 9 months of isoniazid in 1 year, you have to start again. So this is the old, and it's all in our I just had a brain fart, and our TB at a glance. We actually have a table that kind of spells out for you, and thankfully enough, the Texas SDOs also tell you how many doses you have to get in which period of time.
Not sure if this would qualify as a question, but Anna, I guess, is giving us potential hot off the press information, because she says one of our nurses traveled to Chuuk last summer and worked with various physicians from around the world. Word is 4R may become 3R sometime soon.
So they've looked at four months of rifampin and 3 months of rifampin. That was mostly done kind of overseas. I don't know if you're going to see a change here in the U.S. They'll frequently follow behind. The World Health Organization has a whole lot more bandwidth, and so they will pull together experts that will interrogate the literature, get in touch with people who have actually used the medications, pull their data, look at studies, and if they deem it as effective, then we'll have a look at in the U.S. We'll pull the same type of group together for our population. A lot of times things happen overseas. If you can get down to 3 months, that is really cost saving for a lot of poorer countries. If we're a richer country, we may not choose to decrease our numbers just to, if we want to keep the, a higher level of efficacy, we may choose not to decrease ours.
All right, next question comes from Sylvia Diaz. She wants to state that this is in relation to a 24-year-old TB infection patient who is on rifapentine and INH and desires to sunbathe. Is there any concern for sun exposure and the meds?
INH, no. Sunbathing, yes. Just makes me nervous. Sunscreen, please. Lots of sunscreen. Rifapentine, I don't think that's one of the not oh my goodness, clofazimine is probably absolute worst, but I don't think that's in any of the things we need to be concerned about. I think they're fine, but just tell them that you really want them to use sunscreen because we don't want them to die of skin cancer.
Amen. Beth
And the
asks,
one nice thing about the 3-HP, you can see the highest levels of the medications in the first 2 days. So you really have kind of 2 days where you're on that med and then another 5 when you're kind of not.
all right, next question from Beth Walsh asks, what about mild rashes? What is your recommendation for addressing them?
Mild rashes, the biggest is that you start with just the simplest thing, either Benadryl or Zyrtec or Allegra, whatever they have that they take. If they have something that they take for allergies, I would start with that. So you always want to start low with just trying to treat them through it. You can pre-medicate them before it. You can take if you got to be driving, maybe not Benadryl, maybe you want to do Zyrtec. If you want to take your medications at night so you sleep through the itch, then maybe you want to take Benadryl and then take your meds and then go to bed. But the first thing you start with the mild rashes is trying to treat through with an antihistamine.
All right, next question comes from Dr. Yamba. She asks, will insurance providers cover PCP screenings for LTBI based off of the USPTF guidelines?
That is our understand. Yeah, because it has a guideline, it has a grade B, which is like, it's in the like grade A is basically like screening colonoscopies, screening mammograms, all of those type of things have really high levels of recommendation. So yes, and also putting a plug in addition to our TB at a glance, which kind of explains the treatment and it is something that you can forward to your providers. We also have the billing and coding tool. So we have a billing and coding tool that will tell them exactly how to get paid for it. So if you can't get them to screen, dangle that carrot out there, tell them that the U.S. Preventative Task Force has saying that they will, that they have graded this out at B. They will reimburse them, and here's the billing code that you need to use to get it done.
Awesome. Next question comes from Teresa. She asks, if a 5-year-old born in Mexico has now been living in the U.S. for 1 month, has a positive TST but a negative chest X-ray, would they also need LTBI treatment?
So if that child was born in Mexico, he probably got BCG because they vaccinate within days of birth in Mexico. If he's BCG vaccinated, I would always draw an IGRA on that child. If you have a child who is BCG vaccinated, I would draw an IGRA on a child instead of doing a skin test, because that, especially at 5 years, can be false, falsely positive, the TST. So always like my 65-year-old, okay, so a 50-year-old dude, if somebody had done a TST on him and it was positive, and he's telling me yes because I had BCG, I'm like, okay, you had BCG 50 years ago. Do you really think that your immune system still remembers that 50-year-old thing? 5 years ago, absolutely. 5 years ago, he's going to remember that. So his immune system probably saw that a whole lot more recently. I would do an IGRA, and if the IGRA is positive, I would treat for LTBI. If the IGRA is negative and you don't have any other risk factors in that kid, then no, I would consider him negative, and I would just test him with an IGRA going forward.
I have another question. I know that Dr. Cruz kind of piggybacked an answer on it, but Annette asked, Dr. Armitage, I've encountered patients that refuse rifampin due to mentions of nitrosamines.
Yeah, nitrosamines. Yeah.
Yeah.
So that was
How
a
would
big
you
thing.
overcome that?
So basically the risk, they have looked, and the risk of progression to active disease and actually causing physical harm to your child is greater than the nitrosamines. Dick Brostrom works down in the Pacific Islands, and he had a great slide. He basically said 2 hot dogs equals 1 dose of rifampin, which I thought was hilarious. So you can say, well, if your kid eats hot dogs, he's getting nitrosamines. Your kid eats bacon, he's getting nitrosamines. So they're any kind of smoked foods, processed meats, all have nitrosamines. So it's ubiquitous also in the air. Does this increase the risk? No.
All right, next question. I think
There's a lot of people who read on the internet.
Yeah.
That they read just enough to see the risk, but they don't read the part that says there is no risk. The molecules are present, and you feel like I need to tell you that. But for the short course of treatment that you're giving that child and the small amount of medication that is being administered? No.
Next question, I believe their name is Marillis. They're asking, is it still that foreign-born clients should always get an IGRA versus TST?
It just keeps the drama down. So it always comes up with the question. So I ask this question always of people, and those of you who've heard me ask the question know the answer. What percent of persons, if you take all comers, if you just have a person of any age that walks in your office that was BCG vaccinated, what are the odds that they're going to be TST positive? If you ask that person, they're going to tell you 100% because that's what they've been told. But if you want to know the absolute truth is that about 17% of individuals who are previously TST who are previously BCG vaccinated, of those, 17% will have a persistent positive TST. So really, 83% of those can be tested with a TST if it's negative. And when we started off at the beginning with the IGRAs, they're like, don't do that. You know, if you pick the right test in the beginning, but they're expensive. So if you can screen with a TST and then follow it up with an IGRA if they come back positive, that really is not that. A lot of health departments have gone to doing that, and probably not that bad of an idea.
All right, next question. I think this might be our last one because I think I know what you're going to say about it. Comes from Sylvia Diaz. She puts, we're recently getting refugees testing positive. A local PCP who's taking them on, but it's not too experienced with LTBI and has not treated any of them. They've sent them info on treatment, but how else would you approach PCPs to help them understand the importance of treatment and diagnosis of latent TB infection?
Only share the CDC numbers. That or send them to one of the Heartland trainings and we'll fix them.
All right. And
that would be that we could share all of the information at that point. But really, that is the they like CDC stuff. Or the CDC recommendations are, and also you're sending them to them. But are you telling them why you're sending them to them? Are you letting them know? So, doctor, in our population, we're recognizing that most of the individuals who are breaking down we're progressing to active disease in the U.S. have active disease. So we would like to refer them to you for LTBI treatment, not just refer them to you for evaluation, but actually refer them to you for treatment. We have a lot of information on, treatment and, and regimens and information. We also have this really great place they call Heartland National TB Center, where they have, docs who are happy to talk to you if you have specific questions, but we would like to ask you to treat the persons for LTBI. Just let them know that that's what they're coming for.
Okay, so it turns out there might be one more question after all, because I'm trying not to go too far over time. Sarla asks, I guess this is reference to something that you mentioned earlier. What about 8 to 10-year-olds?
What about 8 to 10-year-olds? What about?
Yep, I will say that this came in like maybe a few moments ago, and I'm not quite sure what you might have been talking about at the time. So if we're not completely clear, would you elaborate in the chat for us, please?
8 to 10-year-olds are beautiful human beings. That's usually before they get to the tween stage, when they get an opinion about everything and they can like cut their own meat, wash their own back. They're awesome, small individuals.
Now, I will say, Dr.
With good bladder control.
Yes, that we do have a few more questions. So if you would be so kind as to just respond to them in the chat while I start wrapping things up over here, that would be most appreciative. And I do know that we are just a little over time, about 5 minutes or so, but that's only because we had so many great questions that we wanted to get to. So before we go, I do want to make mention of a couple of things for those of you who are still here. One is that we do acknowledge that some people may be watching in a group setting. If so, yay, you brought a friend. We would like to make sure that you and your friend get credit. So within the meeting chat, I have pinned a comment at the very top. You should have it, where it is a group sign-in sheet. So please, please, please have everyone in your group fill sheet out and complete it and send it back to me so that way we can make sure that you get your credit, because we want to make sure that everybody gets the credit that they've earned here. If you need to, if for some reason you are not able to see it, please feel free to message me through email, and I will get that form to you as soon as possible. But in the meantime, I'm going to share something that everyone, absolutely everyone needs in order for you guys to get your continuing education credits, and that is our participant evaluation. This is required in order to obtain continuing education credits. Please note that these evaluations need to be submitted by the end of day today, March 20th, 2024, 11:59. So that's basically midnight of Central Time. So all of you with the different time zones, please figure out what that means for your specific time zone in relation to the deadline. But essentially, we're going to need that by the end of day today. No evaluations that are submitted after this deadline are going to be considered eligible to receive continuing education credits. So it's super duper important that you take care of this sooner rather than later. And then I have the URL displayed on screen in case anyone needs it. For anyone that needs to hear it out loud, it is at forms.office.com/r as in rabbit /v, lowercase v, uppercase k, lowercase i, lowercase g, uppercase e, lowercase g, lowercase g, uppercase p, and lowercase t. I did test it out. It is case sensitive. So that's why I'm taking the time to make sure that everyone knows what the proper cases of those letters may be. But I am going to leave this screen up for just a few moments while we basically wrap things up for our World TB Day presentation. We just want to take a few moments to thank you all again for taking the time to join us today on this Wednesday to celebrate World TB Day just a little bit early, and for all the information that our speaker shared, we want to say thank you. And for all of you who are doing such great work out there, you guys are superheroes. You just sometimes you put your capes in your closets rather than breaking them out, and we want to celebrate that too. So thank you all again. We hope that wherever you are, that you're having a great day. Please take care. Once again, if you have any questions, please feel free to message me directly at my email. I believe everyone should have had it through some of the correspondences that y'all have been sending me, or through your confirmation messages and your information, your instructions to join. So until then, please take care, stay safe, and have a wonderful rest of your day, y'all. Bye.